Welcome everyone to the October CCG Protected Learning Time session. This is a pre-recorded version because clearly we couldn't hold a live session this month, and we're very sorry about that. Similarly, the reason we are not live streaming it is that many practices have taken the opportunity to run flu clinics during the physical time of protected learning time, and that's an initiative that we're fully supportive of. Before the session starts, I just wanted to say a few words once again to thank everyone working in primary care over the huge efforts and resilience you've shown over the last few months in dealing with COVID. These efforts are hugely appreciated, both by the CCG and more importantly by the patients. We are very, very keen to keep abreast of the pressures in primary care so that we can help identify themes and think of ways of better supporting you. And therefore, if you're under particular pressures that the CCG doesn't know about, please have a low threshold for contacting the primary care team, and we will do our utmost to support you. Certainly reflecting back, this has been the most demanding period in primary care that I can remember, and I'm sure that's true for many of you. And I wish you well over the next few months during the winter period. In terms of CCG activity, we have been working with our acute trust providers to try and smooth out some of the interface issues, which are often cause some workload pressures in primary care. We are working towards a set of shared principles that we could employ, which I'm sure would be greatly appreciated by people working in primary care, secondary care, and most importantly by the patients. I would like to now introduce the clinical sessions. We didn't want to lose this opportunity to share some learning with you, and we had a number of consultants and clinical leads who were very keen to share some important bits of learning, and I do hope you enjoy them. Thank you.
Great. So I'm delighted to introduce Dr. Neal Evans, who's the consultant in pain management at Buckinghamshire Health Trust. He's kindly agreed to talk to us today about the management of neuropathic pain. Last year, Neal and I and colleagues at the Medicines Resource Centre and the Chronic Pain Management team worked together to update our local neuropathic pain guidance, which are available on the formulary website. And Neal's going to talk about these in a little bit more depth now. So thanks, Neal.
Thank you very much, Shona, and welcome everybody. I thought we'd start off by talking in general a little bit about neuropathic pain and why it's such a common problem, and why we decided to write our own local guidance in line with the national NICE guidance that were published last year. So first of all, neuropathic pain is a common problem that we all see both in primary and secondary care, and is caused essentially by a disease or damage to the somatosensory nervous system. It affects an enormous number of people. In recent studies, 7 to 8% of the European population, an enormous number of people, are affected by this. 16% of diabetic patients in the UK have neuropathic pain, and many others. It's clearly associated with a lot of other medical issues. Depression, anxiety, and sleep disorders are rife in this group. And contrary to nociceptive pain, which is a modality of pain we're all familiar with, that pain results from physiological activation of nociceptors or pain sensors by potential or actual tissue injury. Chronic neuropathic pain has no beneficial or fire alarm type effect. It is literally pain for the sake of pain. So neuropathic pain can arise from damage to nerve pathways at any point, from the terminals of the peripheral nociceptors or pain fibers, all the way up to the cortical neurons in the brain and anywhere in between. It can be classified as either central or peripheral, and there are a number of other classifications. Next slide, please. So they can be classified according to location, so either within the spinal cord or brain, or peripherally all the way up to the dorsal root ganglion and the entry into the central nervous system. It's at this stage that we say that there is central sensitization of the pain. We can classify it according to etiology and a number of different predisposing conditions can lead to chronic neuropathic pain. Trauma being a common and classical one, ischemia and hemorrhage. Inflammatory pain can merge to become chronic neuropathic pain. Neurotoxic, commonly from chemotherapy, for example. Neurodegenerative conditions such as multiple sclerosis. Paraneoplastic, associated with tumor growth or tumor cytokines or hormones. Metabolic, such as diabetes. Vitamin deficiency and cancer locally invading itself. The symptoms and signs are usually in terms of pain quality. The pain is often described as burning pain, shooting pain, lancinating pain, often associated with sensory loss or gain, and we'll talk a little bit more about that. And the mechanisms of propagation of this pain is complex and is associated with ectopic or extra discharges within the pain nervous system, a loss of inhibition of pain inhibitory neurons, and peripheral and central sensitization, as I mentioned briefly earlier. Next slide, please. There are some common features that we see in the pain clinic, and these help describe the types of pain, and these will often be in our letters between colleagues in secondary care and indeed in primary care. So I'll just go through a few of them, although this is not an exhaustive list. So paresthesia, which is an abnormal sensation, which can be either spontaneous or evolved during the pain. Dysesthesia, which is effectively an unpleasant sensation. Hypoesthesia, which is decreased sensitivity to stimulation, either tactile or thermal, and both of these are frequent. Hyperesthesia, which is increased sensitivity to a stimulation, again, tactile or thermal, but both together are rare. Hypoalgesia is a diminished pain response to a normally painful stimulus, but that doesn't mean to say that the patient will not report less pain in the area, but when we test it, the response is diminished. Hyperalgesia, which is a much more common symptom, where you get a classic increased response to a normally painful stimulus, and we would often use a pinprick stimulation to elicit this. And probably the commonest symptom that we report in our letters is allodynia, which is pain due to a stimulus that does not normally activate the nociceptive system. This is pain to light touch typically, and we test this by touching the patient's skin with cotton wool, and the patient would perceive this as a unpleasant, often very significant pain, where clearly there should be no pain signal. And this is often due to a mixture of peripheral and central sensitization. Next slide, please. So Shona and I and colleagues from the pharmacy department and also from the pain nursing team went about to try and tailor the NICE neuropathic pain treatment pathway to our own local population. So this applies to spinal or non-spinal neuropathic pain, and there'll be a little bit more about that later. There are a number of general points that we like to make. The first is to give the patient realistic expectations. Chronic neuropathic pain is a long-term, debilitating and significant pain condition, and the patient needs to have realistic expectations about how we might be able to manage, not completely eradicate, their symptoms. To this end, self-help advice is useful, and we should always consider non-pharmacological treatment, such as cognitive behavior therapy or a pain management program. If intolerance occurs, then step down to a previously tolerated level. I think this is an important point. So often patients will start a medication which may be tolerated but not completely effective. And as soon as they get into higher dosing, their tolerance reduces and they will just stop the medication. This is not necessarily the best way forward, as each medication stage is a really important one. We've added in that any medication should be reviewed at 8 weeks, ideally, at the maximum tolerated dose. And if the pain is stabilized, then attempt a dose reduction or withdrawal. And I'll talk more about withdrawal and reduction of doses later. Finally, and again, I'll talk more about this, trying to stay away from oral pharmaceutical agents, we may be able to prescribe capsaicin, which comes in 2 strengths, 0.025 and 0.075% topically, if the patient has a problem taking oral medications, although I believe there is a distribution availability issue with the higher dose of capsaicin at present. Next slide, please. So the first step on our neuropathic pain treatment pathway is a trial of tricyclic antidepressant for the first 8 weeks. The first choice, which has been the first choice for some time, is amitriptyline, starting at 10 milligrams at night. We normally advise about 9 o'clock so that the patient doesn't have too much of a hangover effect in the morning, and increasing up to 30 to 40 milligrams depending on tolerability and patient size and fitness. The anticholinergic burden with other drugs should be checked before starting, and there is a small table in the guideline regarding this. It's interesting that the anticholinergic side effects are really the main reason why a trial of amitriptyline may fail. In particular, sedation may be a problem, in which case we have suggested trialing imipramine at an equivalent dose. Another issue that one sees with amitriptyline in particular is cardiovascular intolerance and palpitations in particular. This may be less of an issue with nortriptyline, again at an equivalent dose should be tried within this step 1. If anticholinergic side effects occur before therapeutic dose, despite use of other agents, then we suggest skipping to step 2. Also at review at 8 weeks, if there's no improvement despite tolerability, we should also move to step 2, which I'll talk about now. New slide, please. So step 2 is a trial of gabapentin at the maximum tolerated dose for 8 weeks, and I'll go into this in more detail shortly. Step 3, which we've added, is possibly combining gabapentin with a tricyclic for 8 weeks together. This may be appropriate, for example, if the 10 or 20 milligram dose of amitriptyline is tolerated and helps sleep, but higher doses needed for neuropathic pain modulation either yield no results or they are not tolerated. So we're therefore keeping the amitriptyline dose at a low level to benefit some of the issues that the patient may have with their condition. The gabapentin may be better tolerated for the actual neuropathic pain symptoms, often of paresthesia and dysesthesia, and the combination in this instance is well worth considering. Step 4 suggests a referral into secondary care for the initiation of duloxetine or pregabalin, again at 8 weeks at the maximum tolerated dose. An assessment should be made at 3 and then 6 months, and a decision to continue or withdraw medication. And I'll be talking about withdrawal of medication, which the group organising the treatment pathway felt was an important message to give. The final step, step 5, is secondary care assessment and prescription of other agents such as anticonvulsants, principally carbamazepine, possibly for trigeminal neuralgia, but that would be a specific diagnosis and treatment pathway which we would assess. Next slide, please. So I wanted to say a little something about dose reduction and withdrawal. When we wrote these guidelines, we felt it was very important to reinforce the message that these medications are not necessarily for the long term, and indeed we would aim to constantly review these patients and the doses that they are taking, and generally aim to try and reduce as soon as pain stabilization is achieved. Again, this needs to be linked to the patient expectation of what pain improvement really is. So we would suggest a review 8 weeks after treatment, as we've previously alluded, and if the pain stabilized with no dose escalation for 8 weeks, to attempt a dose reduction and eventual withdrawal of the medication. This should be done in a stepwise, logical manner. Most of the neuropathic pain medications will take 2 weeks, often up to 3 weeks, to notice a difference. And most of our escalation titrations will be at 1 to 2 week intervals. The same should occur for the de-escalation of these medications. If it's unsuccessful to withdraw or reduce a regular medication, then the medication should be continued, and a further attempt at withdrawal should be made after 3 months. If this is again unsuccessful, then possibly consider a re-referral to the pain clinic or the subspecialty clinic, such as neurology, for example. Regular efforts should be made to reduce these doses and gradually withdraw treatments, as many drugs are associated with safety or dependency issues in the long term, and we'll go into that in a bit more detail shortly. Next slide, please. Next slide, please. Thank you. So tricyclic antidepressants. These are commonly used and have been for a long time to treat pain, headache conditions, and sciatica. They may safely be used with the following medication: gabapentin and pregabalin, although there's a risk of hyponatremia, as there is with all the drugs in this group. So at least reasonably regular UNEs should be measured, particularly when initiating and in the initial titration period. These are the common medications that patients may be on: citalopram at lowish dose, 20 milligrams, duloxetine at 60 milligrams, and sertraline at 50 milligrams. And we certainly see this commonly in our population group. Up and down titration, as I said, should be gradual, and 10 milligrams per week. Common side effects, as we alluded to earlier, are largely to do with anticholinergic effects, sedation, dry mouth, blurred vision, difficulty in micturition, and arrhythmias. And these side effects are reasonably common. Next slide, please. Gabapentin, which has been commonly used for the last 20 years for the treatment of pain, became a Schedule 3 control drug in April 2019. We suggest two methods of up titration: a slow titration in the elderly, the frail, and patients with renal insufficiency at 100 milligrams once a day, increasing very gradually up to 300 milligrams TDS and stabilized on this dose. Apart from renal failure, there is no other particular reason why we cannot increase this further up to 600 TDS, but that decision must be made on a case-by-case basis. We also would consider a faster titration in young, fit adults with no other pre-existing medical conditions, and they can safely start on 300 milligrams, initially once daily, reasonably within about 2 weeks, escalating to 600 milligrams TDS initially. The maximum dose quoted in the BNF is now 3,600 milligrams, but there is some degree of unstable titration above 1,800 milligrams because of the protein binding to gabapentin and the available dose that is free to attach to receptors. I would therefore suggest that we initially titrate up to 1,800, and any titration above that is done slowly, depending on benefits and side effects. Clearly, the dose must be reduced in renal failure by 50%, depending on the creatinine clearance. Again, down titration is as important as up titration and should be 100 milligrams in the slow titration group and 300 milligrams in the fast titration group every 3 to 4 days. Side effects of gabapentin are often reduced mental concentration, memory loss, dyspepsia, and weight gain, and often fluid retention, particularly in the ankles. Next slide, please. Pregabalin has been also a Schedule 3 control drug since April 2019. It is initiated by the specialist secondary care team and continued by GPs if applicable. The initial 28-day supply will be given by hospital pharmacy prescription. The patient is advised to contact the specialist team if there is intolerance or any other reason why we should not continue with the trial. Months 2 and onwards will be continued in general practice. Initially, we suggested 25 to 50 milligrams twice daily, depending on any previous exposure to medications of this kind and the tolerance and tolerability thereof. This can be increased up to 75 milligrams a week later, 150 milligrams BD thereafter, although we may be more cautious and use the lower dose for a longer period if there are any concerns about tolerability. Clearly, this has to be slower in the elderly, the frail, or in renal failure, as we have mentioned with gabapentin. The principle is exactly the same. Again, down titration would be between 50 and 75 milligrams per week over a 3 to 4 week period. New slide, please. Duloxetine has been used for some time and is going to be specialist recommended and GP prescribed. The dosing schedule for this is rather more simple than any of the other preceding medications. 30 milligrams normally taken before 6 p.m. in the evening, increasing up to 60 milligrams after a week. It can cause insomnia, hence the earlier dose, and it's not infrequent to use duloxetine to treat the neuropathic pain and a small dose of amitriptyline to treat any insomnia symptoms or nocturnal symptoms. Side effects. Nausea is a particularly common side effect, particularly in females, in the first 5 to 6 days of treatment, but it normally passes. Insomnia, as I mentioned earlier, headache, and also increased agitation or anxiety. Next slide, please. Tramadol is suggested as rescue medication only, either whilst waiting specialist input or for patients who do not tolerate any of the other neuropathic pain medication. We're advised to point out that tramadol is not recommended for the long-term treatment of chronic neuropathic pain. One must be aware of the serotonergic potential side effects with tricyclics and duloxetine, which tramadol is often paired. We would start off in the usual dose of 50 milligrams 2 to 3 times a day, increasing up to 400 milligrams per day if required. Next slide, please. Capsaicin is a hot chili pepper cream, which is applied locally. Unfortunately, there is a current supply issue, both in the community and in secondary care. It's for the treatment of localized neuropathic pain, in particular those symptoms of allodynia that we discussed earlier. It can be applied in a small pea-sized application 3 to 4 times per day, although patients often find twice a day more practical. For the first week to 2 weeks of treatment, the patient may need local anesthetic cream, such as lignocaine gel or Emla cream, but this tends to be less of an issue after the first 2 weeks. The patient must avoid broken skin, as this is a topical transdermal application. I've also mentioned Cutenza, which is a specialist secondary care application of highly concentrated capsaicin, which is over 100 times more concentrated, and this is applied once every 3 months for areas of localized tactile allodynia, for example, after shingles infection. Next slide, please. Finally, I'd like to discuss a recent development in the NICE guidance, the NG59 guidance, which was originally published in November 2016 and updated very recently on the 22nd of September. This guidance is far-ranging, but I only want to touch on the pharmacological aspects of it, as that is pertinent to our discussion on neuropathic pain. As I alluded to at the beginning, we considered chronic neuropathic pain to be both spinal and extraspinal or non-spinal. This guideline somewhat contradicts that, and guideline adjustment 1.2.16 says do not offer gabapentinoids, antiepileptics, oral corticosteroids, or benzodiazepines for treating sciatica. Having read the fuller preparation of this new guideline, it does suggest that because of the potential significant side effects and dependency issues of these medications, that the pros and cons of prescribing them routinely for sciatica did not meet the evidence base that was required. The next guideline suggests we should not offer opioids for managing chronic sciatica. And if a person is already taking opioids, gabapentinoids, or benzodiazepines for sciatica, we have a duty to explain the risks of continuing these medications, not only in terms of dependency, but also potentially in terms of significant long-term side effects, particularly to do with cognition and mental capacity. As part of a shared decision-making for whether to stop opioids, gabapentinoids, or benzodiazepines for sciatica, discuss the problems associated with withdrawal with that person. Again, this comes back to the message that we were keen to stress at the beginning, that withdrawal should be the aim and not the rare exception. As soon as pain is stabilized, we should aim to constantly challenge the need to be on these medications and try and reduce whenever we can. The final change in the guidance suggests that the risks and harms and limited evidence from the use of non-steroidal anti-inflammatory drugs in sciatica, which I'm sure we are all aware of. In terms of this new guidance, having discussed it with my colleagues in secondary care, we feel that we would still aim to offer a trial of some of these, in particular the gabapentinoids, if appropriate. But we agree that it's very important to try and reduce and stop these if the patients are not gaining benefit. I think that ends my formal presentation on the guidelines. Shona, do you have any points?
Thank you, Neil, very much for that. I've got lots of points actually, so apologies. I thought first of all I would just, because it's such a difficult thing to manage in primary care, I'm just going to summarise some of my own personal reflection and learnings on this. So I think one of the things I've picked up is very much that you've got to give the maximum dose for 8 weeks before you even assess efficacy. And I suspect in primary care sometimes we don't go for long enough and we don't tell patients you've got to stick at this and get up to the maximum dose you can tolerate for 8 weeks before we can say whether it's working. So I think that's one of the things, my take-home messages is that, and that if it's not working, that we should be reducing and stopping the medication before we start something else. Because I think, again, sometimes what we do is we add in rather than stopping. So I think those are two big messages from your talk today. Another point I just want to make was, I think when we talked about the neuropathic pain guidance, I think we said that in primary care, you can start off with a tricyclic. If that doesn't work, stop and start gabapentin. And then if that doesn't work, refer into your team. But meanwhile, then you can continue to try using the gabapentin and the tricyclic at the same time. So I think it's just that, so the pathway is clear for primary care. I think that's right, isn't it?
Yes, it may well be inappropriate to completely stop amitriptyline, for example, if you're getting good nocturnal improvement in pain. And it's really that's the reason why we would use them together. There are some neuropathic conditions where it is recommended as a strategy. For example, difficult to treat post-herpetic neuralgia may well need a two-system approach. The tricyclics will work by the prevention of reuptake of noradrenaline and the descending inhibition pathway, whereas the gabapentinoids work on the membrane stabilization typical of anti-epileptics. So the two pathways are not the same, and you may get a benefit from attacking, as it were, the pain with completely different modalities.
Okay.
So that's the rationale behind using two groups of medication at the same time. But yes, that could be tried. But clearly, by that stage, patients will be struggling and hence forward referral is recommended.
Yes, because if you're doing a stepwise approach to increasing this medication, then swapping them over, for some of these patients, it's going to be months down the line before we're referring in, aren't we? So, and I think the other thing I took away from your message today was about the gabapentin. Although the BNF doses do go up to 3,600, and I think our guidelines, we agreed that we wrote don't really go above 1,800 in primary care because of the risk of side effects. But it's worth a try up to that dose in primary care.
Yes, you can do. The key is above 1,800. The plasma binding becomes non-linear. So you may find that the difference between 1,800 and 2.4 grams is significant. So one tends to be quite aggressive in going up to 1,800 because that's the first point, if you like, of stabilization. But thereafter, the increases, I think, should be done more gently because you can often find a certain dose works, and it varies in between individuals and is not always based on body mass and general fitness.
Do you think we're trying to actually make patients pain-free, or is this about making it pain tolerable? Because, you know, we could be going up and up and up on doses and adding medication in.
I think that's a very good point, Jenna. I think, you know, most of the evidence-based data is based on 50% pain relief, and 50% pain relief is the sort of gold standard that we aim for in any medical pain trial. There's some very interesting work that came out of Henry McQuay's group in Oxford, where I trained initially with Henry, and people start noticing pain relief at 20 to 25% improvement, and that's a very real improvement in their symptomatic pain, and 50% is what we would suggest is a good level of pain relief, and patients will often say 50% is excellent. Thereafter, the trade-off is between the side effects of increasing the dose with possibly the diminishing returns in terms of pain relief. So I think it's worth stabilizing a patient, for example, at 50% relief, and letting them live at that level for a while without necessarily pushing up the dose.
We've lost you on video there for a minute, Neil. So it is, I think it's about setting those realistic expectations at the beginning with the patient, isn't it? Saying that we're not going to get rid of your pain,
yeah,
but we're going to make it more manageable so you can get by on a day-to-day level, doing day-to-day activities.
Absolutely, and it may well be that the goal of the patient is to be able to walk to the shops, for example. Yeah. Well, that can be achieved at 50% relief of pain.
Yeah,
and it's really what is still termed as a functional improvement is what we're looking for. And certainly when opioids were touted as the best thing since sliced bread 20 years ago, that functional improvement graphs were what people were looking for starting opioid treatment. So the same should be thought of really for neuropathic pain treatment. Really, it's the functional improvement that matters, and that can be achieved at sometimes very modest levels of medication.
Now, I know that if we were in a room full of primary care clinicians, all hands would be up on gabapentoids, because I think there's a real anxiety about starting patients on them and the risk of abuse on them and how to stop them. So I think primary care would say we've got a group of patients that we've possibly inherited over the years that have been on gabapentoids of one sort or another for donkey's years. I think they'll be asking how we could manage that group of patients in primary care who are maybe a bit resistant to considering stopping.
Yeah, that's a very good point. So the first point I would make, and the way we would aim to manage it, is to test whether or not the patients actually need the dose they're on. So to bring them in, discuss with them and say, okay, you're on 1,800 milligrams of gabapentin. Do you really need 1,800 milligrams? Or would 1,200 milligrams be just as good? And I would make a planned reduction in dose and patients to monitor this with a pain diary. Now, there are various outcomes from this, but generally I would aim to try and reduce by a third. So let's say 1800 down to 1200. Once they've reduced down over 2 to 3 weeks, or it could take longer, it could be a month, I then give the patients the ability to possibly take an extra dose if they need it or when their pain is bad. And what I have found over the years is that by varying the dose, the patients are only then taking an average dose of 1200. But of course, if they're doing something that brings on their pain, for example, gardening or shopping or an activity that is painful to them, then they can take more, but they must document it and they must keep a diary of it. Now, I found using that approach, the patients will engage in the reduction process because they know they've got a get out of jail card if they need to. And of course, what we're trying to get is data on the individual patient's needs. And if the individual patient, although reluctant, notices that going down from 1800 to 1200 actually doesn't affect the quality of their pain relief, but improves their quality of life because they're not getting side effects, they may go with you on that journey and actually aim for that point themselves.
And I think the patients that you start on pregabalin in secondary care, they continue to be followed up by you, don't they? So
yes, we'll continue to follow them up. And the first point is purely a compliance register where they will phone in our secretary. They're given a number, and provided they're not getting side effects, we'll carry on the escalation. We'll then ring them. I believe we're ringing them at 8 weeks. Our pain nurses will ring them and organise a continued titration, and then there'll be a subsequent telephone call, again, to establish stabilisation, but also to aim to try and wean these patients. So we would expect to be weaning most of these patients from neuropathic medications, particularly the gabapentinoids, within 6 months.
And I think in the letters that you send out to primary care, we've agreed that you'll sort of be writing something about the plan about reducing the medication as well. So it's not one of those sort of open-ended, keep going for weeks, months, or years. So there's a sort of a clear plan.
And I think planning and communication is really, really important, and we're working on consistency amongst my colleagues, so we're all doing the same thing. We're all signed up to try and not only start these medications, but also with a plan to stop them, and so that the patients understand both from us and from primary care that we're all aiming for the same goal of stabilisation, but then reduction.
Going on to a very quick final question. I know that you don't personally, we shouldn't be referring trigeminal neuralgia into you. I think, am I right, it should be neurology or ENT, but what would your advice be on medication for trigeminal neuralgia if we saw a patient in primary care?
So we're quite happy to see trigeminal neuralgia, but it should really have a diagnosis. Most trigeminal neuralgia will be seen by neurology, and because of the modest but reasonable incidence of association with some tumours, particularly pontine angle tumours, they will almost all, as part of the protocol, need to have an MRI scan of the brain and that interpreted. So generally, either max fax, possibly ENT or neurology would also be involved. And so in terms of management of pain, of course, we're very happy to deal with that. They tend to be better with the membrane stabilizing anti-epileptic drugs. So we would normally start with carbamazepine, which is almost a diagnostic test of trigeminal neuralgia. We'd start off normally with 100 milligrams once a day, increasing to twice a day, and it's fairly typical to need between 600 and 800 milligrams in the first instance to try and get control of the symptoms. I normally suggest the liver function test at about 4 to 6 weeks after starting carbamazepine, and another one at about 6 months, just to make sure that you don't get cholestasis. When it works well, carbamazepine is remarkably good for trigeminal neuralgia. The diagnosis of trigeminal neuralgia becomes a bit complicated by the so-called trigeminal neuropathy and other idiopathic facial pain. So it's really important to get the diagnosis right, because idiopathic facial pain is better treated by tricyclics.
Okay. Thank you for that. And I think it's probably worth just highlighting to everyone that the neuropathic pain guidance is on the BUCS formulary. It's available on the BUCS formulary for everyone to see, and with a stepwise process for management of it, with all the stuff that you've given, detail you've given us today, and including the fast and the slow dose increase for gabapentin.
Yes, and there's also sections on there for renal insufficiency, and so on and so forth.
Thank you. Neil, thank you very much today for that. Really appreciate that, and I hope that's been informative to everyone.
Hello there, I am Sian Roberts. I'm the Clinical Director for Mental Health, Learning Disabilities and Dementia in Buckinghamshire. And today I am speaking about the importance of an annual health check in improving the health outcomes and reducing health inequalities for those with learning disabilities in Buckinghamshire. And really, I just wanted to highlight some of the opportunities that we particularly have this year, where we can if we were to optimise, we can increase and improve the uptake of annual health checks. So next slide. So why is this particularly important this year? We've all had a tough year this year in the NHS due to the COVID pandemic, and in primary care we have certainly seen that many routine health checks have been appropriately paused. However, in the third phase of the NHS response, Simon Stevens has actually asked primary care to resume the learning disability annual health checks as a key priority. And the reason for this is that there's already a significant health inequality gap, which I'll go on to explain a little bit later. And this has been widened during the COVID pandemic, but also sadly we have seen increase of number of deaths nationally. And so this is why this has been called as a priority. So there are really 4 different opportunities that I'm going to for you to consider really to improve on your annual health checks. We've had the historic learning disability annual health check, DES, which has been going for quite a few years now, and for this practices will still be receiving about £140 per check, and that is something which is still ongoing. For this year, practices also have an additional piece of work, which is the QOF Quality Improvement module. There are 2 modules this year. One is on early detection of cancer, and the second is about improving the health outcomes for those with learning disability. So clearly the work with improving annual health check uptake can certainly support that particular module. In addition to the practice targets, we've also got 2 PCN models which can also improve the annual health checks. We have the PCN Investment and Impact Fund, which I'll go on to talk about a little bit later, but also to be mindful that the PCN DES care home support for this year is not just for the elderly living in care of the elderly care homes, but also for those who are living in CQC registered LD care homes. Next slide, please. So with regards to the primary care investment and impact fund, this actually was paused during COVID, but is now in situ as of the 1st of October. And this is very similar model to that of QOF at the practice level, but instead of a practice level, this is really giving a PCN target to achieve. So if all of the practice within the PCN at the end of the year can achieve at least 49% collectively of annual health checks of those on their register, they will receive a lower amount. And obviously, if they receive, if they have achieved well over 80%, they will be eligible for a higher amount. So this would be a good thing for PCNs to start monitoring. Next slide, please. So if we can start with the national target, for year 2021, the target is 67%, or 2/3 of those on GPLD registers who are aged 14 and above should have an annual health check. Next slide, please. So we could say, well, why? Why does this group particularly have to have an annual health check? And for me, the answer is very compelling. There are significant health inequalities in this cohort. We do know that by having a learning disability, that you are 52 times more likely to die before the age of 50 compared to those without a learning disability. And of those who die, over 1/3 are likely to have died from a preventable cause. And this compares much less favourably to 9% of the general population who may have died from a preventable cause. In Buckinghamshire, in the LEADER review, which is the Learning from Death review, which is an ongoing programme, in 1920 they've confirmed that over 2/3 of our patients who died with LD, they did die under the age of 60, which is quite compelling. So the reason, therefore, for having an annual health check is really to detect a preventable health condition, whether this is cardiovascular, diabetes, asthma, etc. But it also can endorse and support people to make changes in their lifestyle for prevention and really to prevent progression to another preventable disease. So really supporting them with accessing weight management and exercise, for instance. Next slide. So this is this is what we achieved last year. So our national target is 67%, and even last year, sadly, we fell short at 48.8%. This was mitigated a little by the fact that in March the COVID pandemic started, and of course we probably recognise that a lot of these learning disability annual health checks do take place in that final quarter. However, saying that, in previous years, we have, I think the most that Buckinghamshire has been able to achieve is around 55%. So we are still way short of the national target of 67%, which is where really, if we can start looking at those 4 key opportunities we talked about earlier, both at practice and at PCN level, to optimise, we may be able to increase this and improve this level. So I think just with regards to how can PCNs increase and optimise uptake? So other than actually monitoring the data, there are some innovative ways that PCNs may want to consider improving this particular target. So for instance, you may have where you have a practice who has a special interest in improving annual health checks or conducting them, and they may want to consider delivering annual health checks for patients in neighbouring practices. It could be that some PCNs might want to consider pooling resources that are available to fund an LD health check team, which could include a nurse or a doctor in order to complete those health checks as a PCN. So there are lots of ways that PCNs could use the available funds already in innovative ways, perhaps to deliver the health checks rather than just at purely practice level. The other thing that is that practices can consider how to use some of their appointments for health checks. So for instance, they may want to consider using extended hours or improved access appointments. We know that practices are less busy with less people coming through their surgeries at these times, and this perhaps may enable people to feel more comfortable to attend for an LD health check. So once again, so we've got lots of ways that perhaps people could consider improving on this. There are PCN and practice level dashboards which are updated monthly, and they are published on the BBC on the CCG website, and also we have created an LD TeamNet page which is, the data is also published. And a final reminder is to practices to make sure that obviously the health checks are coded, and they can use the EMIS National Learning Disability template, but also the latest Arden's Learning Disability Annual Health Check template would also ensure the correct data is captured. Next slide, please. So we talked about the numbers of annual health check, but if we were to look at the LD annual health check DES, it also specifies that every patient who has an annual health check should be given a health action plan. So the health action plan is a summary of the areas that a patient may want to address following their annual health check. And in Buckinghamshire, we are ahead of the curve with regards to providing action plans, as it is a very similar approach to the care and support planning approach that we've been doing for those with long-term conditions, in particular diabetes. And the idea is at the end of each annual health check, a personalised action plan of targets is created, which is an agreement between the clinician and the individual. And on this slide, you can see two examples of health action plans. One is very simple words, that's the one on the left. And on the right, we've also got a pictorial or easy read version. And it's important that a copy of this is provided to the patient, as well as of course, being filed in the notes. So some examples of potential targets. It could be that somebody has said they're struggling with headaches, but in fact they've not had their eyes checked for over 5 years. So an action would be to encourage them to visit the optician in the next month or so. The other thing is that they could be overweight, and so the GP would suggest attending the Live Well Stay Well service. Actually, I do want to just flag the Live Well Stay Well service in Buckinghamshire. They are very, very open and supportive for those with learning disabilities, and it would be an appropriate action for GP to support a patient with a referral rather than relying on them to self-refer and highlighting their learning disabilities in order that the Live Well Stay Well service can give them the reasonable adjustments to support them. So a health action plan is important, and of course, as said before, it's important that this is coded. So next slide, please. So how have we done in Buckinghamshire? In principle, if we have done, as we know, 48.8% of our patients with LD have had a learning disability annual health check. In theory, 100% should have therefore received a health action plan. And sadly, it looks like only a quarter of those who had an annual health check were given a health action plan. So I would propose that this is an area of quality improvement to consider in order to improve. So next slide, please. So other than the annual health check, another key priority for our population generally at the moment is to increase the flu vaccination uptake, and this is even more of a priority for those with learning disabilities. It's important to flag that every patient on the Learning Disability Register is eligible for a flu vaccination. It has been noted in previous years that EMIS has not necessarily prompted or highlighted this eligibility, which has meant that some patients have been inappropriately denied a vaccination. So really just want to reiterate that every patient, regardless of age, is eligible. So next slide. So if we looked at last year, we recognised there was a significant difference in our flu uptake compared to the general population, less than 50% or 46.8% uptake compared to well over 70% uptake in the general population. So once again, this is a really key area that perhaps we can focus on improving this year. It'd be good to note that if a patient is needle phobic, whilst it's not effective, quite as effective, it would be appropriate to offer the nasal vaccination as a reasonable adjustment. Although practices would have to do this via a patient-specific directive, but this would be a way to improve uptake. Next slide. So once again, just another slide to show that our uptake has been below national average, not just last year, but this has been a general trend. So it would be good to see that we can get this up to the same level as the general population. Next slide, please. So the final area I just want to flag a big inequality is with regards to cancer and cancer screening. We know that patients with learning disability die prematurely, as we've talked about before, and some of this is not just about cardiovascular and preventable conditions, but also die prematurely from either undiagnosed or very late diagnosis of cancer. And we recognise that in this group that cancer screening uptake is extremely poor. So the LD annual health check is an opportunity to check that a patient has completed all their relevant cancer screening. And if not taken this up, it's an opportunity to support and encourage that they do complete this. And there are a number of easy read leaflets available that clinicians can use to support patients with gaining their confidence to complete the screening. This graph just shows the national picture, which shows that in all categories of screening, the uptake in those with LD is lower than that of those without LD. So how are we doing in Buckinghamshire? Next slide, please. So sadly, in Buckinghamshire, the trend is very similar to that of national figures. In fact, the bowel screening uptake is actually pretty good. However, we have noted that the breast screening uptake is less than 50% eligibility. One of the areas that we've been looking at in Buckinghamshire is how we can improve upon this. And the breast screening team at the hospital are now asking practices when they're coming to the area whether they have patients who are on their list who are due to be screened, whether they have any learning disability. It would be helpful for practice to let them know of these patients, and the reason for this is that the breast screening team are unaware who has a learning disability, and the invitation that is currently sent out to the population is probably not very friendly or understandable for those with a learning disability. If they are identified, then the breast screening team are now sending an easy read invitation and even calling the patient directly to invite them, as well as providing additional support at the time of the screening. So this would hopefully encourage and improve the uptake, and something that practices can support the breast screening team with. Next slide, please. And on this slide, this is particularly concerning, is that once again, in line with the national figures, we note that cervical screening is particularly poor in this group, with less than 25% having who are eligible having a cervical screen. We've had a little look at this in Buckinghamshire, and it is noted that in the annual health check, that very few people have been asked about their sexual health, and as you can see from the bottom graph, it's around 14%. We've hypothesised why this might be, and it's felt that it's probably due to clinicians feeling uncomfortable asking about sexual health, but in fact it's a vitally important area to explore. From this, it will be an opportunity to really ask about cervical screening and promote cervical screening, because even if a woman isn't sexually active, they are still eligible for a smear. The other reason that it's important not to overlook this and assume that a woman and or a man isn't sexually active is that actually whilst they may actually be sadly be exposed to sexual abuse, which unfortunately is far more common in this cohort. And by exploring sexual history, this actually may come to light and to be able to offer the right support. And indeed, if they are sexually active, whether that's consensual or not, it is of course important to consider options for safe sex and contraception. So these are two areas that certainly practices and clinicians might want to consider improving upon, really around asking gently around sexual health, and also of course improving on the cervical screening uptake. Next slide, please. So in summary, we have quite a few areas we can improve on in BUCS, and practices and PCNs may want to consider some of these areas to work on. And what we've covered today, annual health checks, health action plans, flu uptakes, cancer screening. We've been able to create a practice level learning disability dashboard that includes all of these figures on a monthly basis. As alluded to before, we've also put lots of resources on our BUCS LD Clarity TeamNet page for any support to deliver a health check. And likewise, the RCGP toolkit is the gold standard really know-how tool to conduct an annual health check. Next slide, please. The other important thing to consider are reasonable adjustments. The reason that uptake can be poor is that actually people with LD find it tricky to access healthcare due to anxiety or fear, as we've mentioned before. And this is where Talkback has given some very helpful tips for practices to consider to make reasonable adjustments to support a patient to attend. Next slide. Another very key group to support annual health checks is the Community Learning Disability team, and on this slide we've got some contact numbers here. One of their roles is to actually support people who perhaps are not attending practices for their annual health check, despite the efforts of the practice, and they can give a very personal approach to support that patient to attend. Next slide. This is the social care team in Buckinghamshire, who can particularly support on social or advise on social activities, housing, finances, and that's another very key contact that might be helpful. Next slide, please. I've already talked about Talkback with the reasonable adjustments, but they also have lots of involvement groups and they support self-advocacy. So once again, a good team to be aware of. Next slide, please. At BHT, we have liaison nurses who are will support patients when they are attending the acute trusts. They will support people coming through A&E, but also they would also support people who are coming in for procedures, whether that's investigation, surgery, or even outpatients. And therefore, it would be helpful when patients are referred to the hospital that GPs can flag that the patient has a learning disability, and from that flag, a liaison nurse will be allocated to them when they attend the hospital. Next page, please. And of course, we mustn't forget the carers of those with learning disabilities who also might need support. And this is the details for carers BUCS. Next slide, please. So I've come to the end of the session, and I hope that together we can collectively improve on the uptake of learning disability annual health checks and flu vaccinations in Buckinghamshire this year. It's particularly in these challenging times, and hopefully by doing so we can enable our patients, our cohort with learning disabilities, to live longer and happier lives.
Okay, so I'm delighted to present Joe Hicks, who is a consultant paediatric orthopaedic surgeon at Bucks NHS Healthcare Trust. I think many of us have issues, often in primary care, with children presenting with funny legs, funny feet, various different orthopaedic problems, which we sometimes scratch our head about. And it's really great that Joe's agreed to come and talk to us about some of the common conditions that we see, particularly with lower limbs in primary care. Thank you, Joe.
Okay, thanks Judith for asking me to come and have a chat, and also to the there are a few people logged in live on this, so hopefully we'll get a little bit of interaction, and we can ask for questions in the middle, but mostly at the end. We had a bit of a chat about topics to cover, and I think initially we were going to talk about just hips, but I felt that perhaps we ought to start with an introductory section covering the whole of lower limb, which is actually the majority of children's orthopaedics, with a view very much to this being part one, and then we could do some more focused sessions later. So as people are listening to this, have some ideas about where you'd like me to go, perhaps into more depth later on. So as Judith says, I'm actually the only consultant paediatric orthopod at Stoke Mandeville and Wickham. My practice is elective, and so emergencies are still handled by my adult T&O colleagues, and I'll just cover that briefly. Can we have the next slide, please? So I thought before going into the details of some of the clinical conditions, I just did want to run through the structure of the system pretty much as it is at the moment. And we're doing this talk in sort of going into perhaps a second wave of the COVID crisis. So things are slightly different at the moment, but I think the principles are still the same in terms of who you should refer to or ask for advice. Then I'm going to go through specific conditions affecting the lower limbs. And then at the end, as I said, I think it would be nice to try and make a bit of a plan for further sessions going into more depth, either on these topics or other ones. So can we have the next slide, please? Now, there are obviously, as you know, various options for referring or for asking for advice or for investigating any child that you see with an orthopaedic problems. And the first thing I've put on the top is to know to use advice and guidance requests. Now, I don't think for any of the adult trauma and orthopaedic conditions you tend to use that, because I do see, I think, all the requests that come through. But people are contacting me through this system, only at the moment for 3 or 4 a week, but I'm very happy. And I think I'm quite quick to respond via that system. Obviously, it's usually about specific referral conditions, but even for more general advice, I'll just mention that again at the end. But I'm happy to take email questions if they're perhaps not about specific patients. But because I have an elective practice, I don't have, at the moment, I don't have any fracture clinic or an on-call presence. So if you have an emergency, so a child where you think they might have septic arthritis or osteomyelitis, obviously with trauma or conditions such as a slipped epiphysis, you do need to contact the emergency team, so the on-call T&O team. The patients that I do see urgently, in inverted commas, i.e. within a week or so, particularly are the babies. So direct referrals to me come usually via the paediatricians for babies born with unstable hips or with club feet predominantly. Now, the next question is around X-raying, and I think there's a bit of a reluctance these days to X-ray children's hips, and actually a single X-ray is a minimal dose, and if it excludes a significant hip pathology, then it's well worth considering. And the ones I particularly had in mind there are the SUFI, slipped upper femoral epiphysis, sometimes called SCFE, which is capital femoral epiphysis. Talk a bit about the condition later, but if you think you may have a child with a slipped epiphysis, then AP and frog lateral x-rays are very valuable. And similarly, if you think a child may have DDH, whether it's because of symptoms or there's a query about screening, then a pelvic x-ray, a single view pelvic x-ray, will essentially rule out DDH. So again, that can be valuable for reassurance. And I suppose the final clear category of it's worth getting an x-ray usually is a benign feeling bony lump. So it's probably going to be an exostosis or something like that. And you shouldn't be worried about getting an x-ray. Ultrasound's also obviously used, and classically people think about it for irritable hips. If you uncover, if you like, a missed screening DDH, so mum says my baby was breech and they said that they needed an ultrasound but it didn't happen, they can be requested by yourselves, and it's just a question of meeting the criteria on the request. But if there's no clinical abnormality but a clear risk factor, so a first degree relative breech or foot deformity, then it's probably much more efficient for you to request it yourselves than to ask me to do it, because I may not pick it up for a little while. Talking about physiotherapy now, that usually should be your first port of call for anterior knee pain, low back pain with no red flags, many of the conditions that you would ordinarily see in adults too. And I think most people are probably aware now that the paediatric physiotherapists who with this trust are based in the community generally see the sixes and unders, but they also see older children with neuromuscular conditions, so cerebral palsy, spina bifida, other neuromuscular things. And then the rest, the normal adult physiotherapists based in the hospital, will see older children, and some of them actually do have a relative specialism in the children. So I think some of the physiotherapists tend to see adults, but some of them are very good indeed with children. And then finally, I've put myself down kind of as the last resort. So if the above don't apply or haven't worked or haven't given you the answer, then of course refer to me. And at the moment, I'm the only specialist paediatric orthopaedic consultant in the trust. I would certainly say with older children, so 14, 15, 16, with a clear knee pathology, say an ACL injury or something like that, it may well make more sense to refer to an adult specialist, because that would be where I would send them. So starting at the bottom, I just want to point out, and I imagine everybody here is aware of this, that it's normal to be flat-footed when you're a baby or a toddler. So if a parent complains or worries about their child's feet rolling in, you should generally reassure, if everything else is normal, that it's likely just to spontaneously improve with time. You may not want to promise them that they're going to have high arches, because of course the spectrum of older children and adult feet includes a degree of flat-footedness, but just know that they will improve. So the next category of actual abnormality, if you like, are the foot deformities present at birth, which people like to call positional talipes, and usually mean a positional club foot, so a turned in foot. Now, the term talipes just translates as ankle foot, and there are various forms of talipes, but I think the same principles to all intents and purposes at the moment apply to whether the foot turns in excessively, turns out excessively, is slapped up against the tibia, etc. And essentially, if it can be passively corrected to a neutral, normal position, it probably will spontaneously resolve without any stretching, and many of them don't need to be seen by me. If in doubt, then refer to the paediatric physiotherapist, and if either it was expected spontaneously to correct or with stretching and it doesn't, then of course refer on to me. And it's worth knowing that all the types of physiotherapists, so both the paediatric physios and the adult physios, are very quick to refer on to me if necessary, and they usually send me an email, so it's pretty much instant. So you don't have to be worried if you refer to a physiotherapist, that it won't come quickly to me if it's not something they can deal with, and usually they can cope with that in the first. There's a raised hand there.
Hi, just wanted to ask Dr. Hicks, the podiatry team, they sometimes see children.
Yes.
Will they also refer to you if needed? Lovely.
Yes, they will. I didn't mention them because I didn't want to overcomplicate it, but yes, they do. There's at least one specialist paediatric podiatrist who will tend to refer directly to me. But yes, they will and do. So again, if you send them to the podiatrist in the first instance, if they've got any concerns, they'll come to me. Okay. Next slide, please, then. So the structural club feet probably don't trouble you particularly, certainly not in the first instance. So these days, about half of them are actually picked up antenatally, and I'll usually get a chance to have a meeting or chat with mum about the treatment, and the rest are picked up at birth. And the characteristics of these are, of course, that they can't be passively corrected, and we use the Ponseti method of serial casting, followed by Achilles tenotomy, followed by a boots and brace. They obviously all come to me, and generally speaking, the paediatricians will send me an email, even if I've seen them beforehand, seen the mum beforehand, because it's very helpful to get in there early. The neonate foot is nice and flexible and responds really well. But having said that, even when they're picked up later, or starting treatment later, which is something that did happen for a while at the beginning of the lockdown phase, they still seem to do well. It just might take a bit longer. And if there are, usually a clubfoot is an isolated abnormality, it quite often is familial, and the child is usually otherwise normal. One or two appear every year where there's probably an underlying neuromuscular or syndromic condition going on, in which case they'll also be seen by the paediatricians. Could I have the next slide, please? I've already talked a little bit about flat feet, which are normal in the younger child. And when they are flexible, you can test this by getting them to stand on their tiptoe, and you'll see a bit of an arch form. You should see the heel swing from the normal slight valgus inwards to a slight varus position. And when it's a rigid foot or a stiff flat foot, then that movement doesn't happen. Occasionally a flat foot is secondary to a neurological problem, in which case there could be other signs. But as a general rule, and I think, again, people probably know this now, there isn't any evidence at all that orthotics can affect the natural history of flat feet. And in other words, that means there is no point in prescribing them for asymptomatic flat feet, despite mum telling you that they were in Eastern Europe and it was absolutely essential that they had their orthotics. There isn't evidence for that, certainly not at the moment. However, if they're painful, and sometimes that pain is in the foot, sometimes you feel it might be causing knee pain or other symptoms, then it's worth trying basically arch supports. We're not sure whether custom orthotics or just off-the-shelf ones are effective, but it's often worth a try. And I'm happy to see any that are either painful or stiff, or if it's unilateral or there's anything funny about it. The next slide, please. Occasionally, some of these other conditions present. With bunions, as a general principle, there isn't any indication for surgery before skeletal maturity, and hopefully not for a long time after that. And that the main reason behind that is that there's a very high risk of relapse. While the foot is still growing, it wants to return to its bunion shape, basically. So if you do a corrective osteotomy, it will recur. So in general, advise sensible shoes with obviously a wide toe box, feeling inside the shoe to see if you can feel a seam which might sometimes press on the bunion itself. Occasionally an orthotic can help. So if you try an arch support type of orthotic, which again might simply be off the shelf, it can help to lift the first ray and just take pressure off the bunion side. But on the other on the other side of that one, if the problem is pressure on a bunion, stuffing an orthotic into the shoe is usually going to make it worse because it needs room. Curly toes, you'll see in babies and younger children often, and if they're asymptomatic, they don't need treatment. And sometimes it's not that straightforward to know whether there is any symptoms. And parents quite often appear and say, well, they don't like wearing shoes, or they want to be carried after a period of time, and they feel that it might be due to the toes being curly, but it rarely is. Unless you can see signs of redness or rubbing or nail problems, then it's usually not going to be that. And asymptomatic curly toes do not need any sort of monitoring or treatment. There isn't any evidence that stretching or taping help. However, if they are painful or very stiff and actually causing problems, then it's relatively straightforward to treat them with a flexor tenotomy. So I'm happy to see them. The next slide, please. So we're talking about toes, but not really about toes anymore. So in-toeing, which means you are pigeon-toed, and as opposed to your feet turning out. And so it's nothing usually to do with the toes. It may be to do with the foot, where there's metatarsus adductus, where the forefoot turns inwards, or the shins, where the shin is twisted inwards, or the hips, where they tend to turn in. And sometimes it is associated, particularly in adolescence, with knee pain, because it can affect the way that your quadriceps work. But in-toeing is essentially not something that there is ever a requirement for surgical treatment for. Occasionally in children, particularly with cerebral palsy, then derotational osteotomies are used, but almost never in an otherwise normal child. The significance really of in-toeing, certainly when I see it, really all I'm interested in is, could there be an underlying neurological cause? Because of course, in a sort of diplegic cerebral palsy, typically they will have a tendency to in-toe. And obviously if there's an underlying or potentially an underlying neurological cause, then the paediatrician should have a look so they can investigate further. The next slide, please. Again, talking about toes, but not really. Toe walking is so common that we treat it as being a normal up to the age of 3. But I've put in brackets there, depending on severity. So if you see a 2.5-year-old right up on their tiptoes, never coming down, tight calves, then that's likely to be a problem. If you see a 2.5-year-old who was up on their toes, but now they're less so, and it seems to be getting better, then that's going to carry on and sort itself out. Again, it's a gait pattern where there might be an underlying neurological abnormality, and I think sometimes there is an undetectable neurological abnormality, if you see what I mean. If there's been a difficult birth or prematurity, and they have other factors of the gait which make you suspicious, then it might need referral to the paediatricians. There are a couple of raised hands there, I think.
Yeah, thanks, Jo. I just wondered, sometimes we get people who feel that toe walking is associated with like ASD, and sort of cite it as a symptom that they think is significant and that means their child is more likely to be autistic. Is there actually any evidence for that?
Yeah, well, there definitely is an association. So a fair proportion of the toe walkers that end up needing some sort of treatment are on the autistic spectrum. But I couldn't really answer whether it is considered a diagnostic criterion for autism. I certainly find myself tending to reassure people if I see a child with toe walking, and they seem otherwise okay to me, given that I'm not a paediatrician and I don't really have much experience of diagnosing and managing autism, I tend to say, your child looks normal to me. I don't think, it's not pointing me towards thinking they've got autism. But that would be something I think that a paediatrician would have to consider. Yeah, so they're absolutely, quite a lot of them, and some of the more difficult ones to manage are autistic. But one of the phrases I find myself often saying in clinic is nobody ever died of toe walking, which probably isn't true actually, but it's sometimes I think we might over-treat. So people who children who are left with a bit of a bouncy gait but otherwise are fine probably don't need massively aggressive treatment. But the ones that we worry about, or that come to me, are if they haven't always toe walked. So it's normal if when you started to walk you were toe walking, but not if you started to walk with your feet flat and then you come up on your toes. In general, although I have seen children in whom that happened and we couldn't find a cause. If it's unilateral asymmetric, then obviously one has to think about a neurological thing. And those that don't respond to physio, I will see and initially probably treat with casting and later on with tenotomy if that's required. Could I have the next slide, please? Now, I quite often get asked to see children with multiple joint issues, and I don't feel really that's my area of expertise or training, and I just feel that I would rather be referred those specific joint problems, and that perhaps other specialties may be more appropriate, if at all. I currently feel that there's an epidemic of diagnosis of hypermobility, and even worse than that, Ehlers-Danlos loss, and it's definitely causing a few problems in the rheumatology community, or the paediatric rheumatology community, with overdiagnosis. But generally speaking, obviously children are bendier than adults, and if you use the standard Baton scoring system, then most children will score more than their parents. So if there are generalized aches and pains, then you might want to be checking the bloods, obviously vitamin D or a full blood count in case there's a hematological malignancy. And the paediatricians or rheumatologists are likely to be a better bet if appropriate. I also quite often get asked to see clicky joints, and with them, unless there's gross instability or there's pain, then it's likely to be normal and you can reassure. That's probably all I want to say on that, unless anybody wants to take me to task about hypermobility, but that is probably a talk on its own, and certainly a debate on its own. And if you think about it, there's not much you can do about being what we used to call double jointed. Physiotherapy may help, and if you feel you need to do something, then referring to physiotherapy for core strengthening and coordination exercises probably is the most useful thing to do. Could I have the next slide, please? We won't spend too long on bow legs and knock knees. Obviously, bow legs are normal in a younger child, a toddler particularly. Check the vitamin D if there's concern that it's worsening or there are any other concerns about their health. But if it's very asymmetrical, or it keeps on after about 2.5, 3 years, then I'm very happy to see. And I'm happy to see if the parents just need reassuring. Also, the appearance of bow legs is always exacerbated by significant tibial torsion. So in other words, if the tibia twists in, it makes the bow leg look more marked. And you do get 1 or 2 18-month-old children with really quite alarming looking legs. And if they look alarming, you can send them to me and I'll be alarmed, but just keep an eye on them probably. And a similar thing with knock knees. So Jenny Valgum's normal in an older child, about 3 or 4, but it should gradually resolve as they grow. Happy to see if there's pain associated with it, or if it's extreme, or if it's getting worse. The next slide, please. We've talked about anterior knee pain already. Some factors predispose, so being female, it's almost universal. Excessive knee valgus, squinting kneecaps. In other words, if you've got femoral anteversion, your hips are turning your knees inwards, often your tibias are turning your feet back out again. So you might have your feet pointing straight forward, but squinty kneecaps. That definitely predisposes to anterior knee pain, and it's usually patellofemoral dysfunction that's the problem. Physiotherapy is the first line of attack for that, and firm sort of reassurance that it will disappear, or the tendency will go away or become much less marked once they are skeletally mature. A special case for Osgood-Schlatter's, which is an easy diagnosis because you can put your finger on the tibial tuberosity and it's tender and usually swollen. And if you can't do that, if it's not tender over that spot, it's probably not Osgood-Schlatter's, but if it is Osgood-Schlatter's. And the advice on that these days, along with some of the other apophysitis type conditions, is that you probably don't need completely to stop sport. Some sport or activity is okay, even if it seems to stir it up a bit, as long as the child and their family know that it makes it a bit worse, but they're prepared to put up with that because they really want to play. It's unlikely to cause them any long-term problems. The next slide, please. A bit like with clubfoot, I'm not going to go into terribly much detail here because this is usually DDH should be picked up, although the baby checks aren't 100% sensitive. That's not anybody's fault, it's just how it is. They can't pick up everything at the first check. But because early treatment is vital, if you think you see a baby at 6 weeks or even later, of course, and that there may be some abnormality there, and at 6 weeks, rather than instability, you're probably much more likely to begin to notice an asymmetry of abduction in particular. So you might not feel the hip going in or coming out. You might not be able to pick up a leg length difference in a wriggly baby. But abduction is often the key thing there. And if you're worried, I'm very happy to see iScan in my clinic, so it's no trouble at all. And let me know by email because and through ERS. Just don't send it through as a routine, because obviously come 6 weeks we do need to get treating early if there is something there. The term clicky hip isn't meaningful, and it's not used in orthopaedics, but it is used outside orthopaedics. And if you examine a baby and you feel a soft tissue click but there isn't any instability, or as we mentioned above, abnormality of range of movement, then there's no association with DDH and they don't need to be seen. However, parents will have often looked up clicky hip or become anxious, and I am actually very happy to see anxious parents where that's the diagnosis. So if even if you're happy and you know that they shouldn't really need an ultrasound, if you let me know, then it doesn't take very long for me to see them in clinic and do a scan and everybody's happy. But if you see, as I mentioned before, a baby where they should have had a screening scan, please can you put in the request yourselves. Next slide. This was going to be the topic of the whole talk, but I'm actually going to skip through it. DDH can present late with a waddling gait or pain or in the hip or even back pain, and you can diagnose that with an X-ray. And obviously I'd see them. Acute septopefemoral epiphysis is when the proximal femoral epiphysis suddenly moves. There may have been previous symptoms, so you can get an acute on chronic. So they might have had some sort of niggle, they might have had knee pain, and that's the classic way to miss a SUFI, is that they often feel the pain in the knee and not specifically in the hip. The typical patient is an overweight teenage boy. They may already have an externally rotated leg, which becomes often more externally rotated due to the mechanics of the slip, and they dislike internal rotation. So if they present acutely non-weight bearing, that's an emergency. Please treat as for a fracture. And if you find yourself requesting an X-ray, it must include a lateral. Septic hip, well, septic any joint is also an emergency if you suspect that. I don't think we need to go through the clinical signs, but basically an unwell child, loss of weight bearing and signs of sepsis. But if it's a more chronic picture, then please send to me and I'll do the necessary. If you have specific queries, use the ERS if that's patient related, but if it's not, use my email address and I'm very happy to hear from anybody with questions or even debate, including stuff I've raised today. And please use that to back up urgent referrals, particularly when there are babies.
Okay. Thank you very much, Jo. I think that was, I know it was a bit of a whistle-stop tour, but I think that was incredibly helpful. Thank you. I suspect there will be more thoughts and questions and everything, and I think that there will more come after more people have watched this recorded, and so we will most definitely be getting back to you, I'm sure, to be potentially having either a slightly longer session or possibly even some case discussions. So thank you very much.
My pleasure.
Good afternoon, everyone. My name is John Black. I'm the Medical Director of the South Central Ambulance Service, and I'm joined today by Will Hancock, who's our Chief Executive, and Lucy Stevens. And we've been invited today to talk about a new national initiative, the 111 First Service, which we're very excited about, and we've got an opportunity to tell you a little bit about our experience with this new service to date. Next slide. So the South Central Ambulance Service, as have all ambulance services in England, has rapidly evolved over the last 10 years. And there are now three key components to our service. We provide the 999 service throughout the Thames Valley and Hampshire and Isle of Wight. But in addition to that, we also run the crucially important patient transport service throughout the South Central region, but also in Surrey and Sussex, and also the 111 service, and now host the integrated care service. And our clinical strategy and our ethos is based very firmly in providing our patients with care coordination and integration. And we're now providing services to just over 7 million people. Clearly, our role is to ensure that patients receive the right care first time, and clearly we want to achieve the very best clinical outcomes and experience for our patients. We're also absolutely determined, by working with our colleagues in community and indeed primary care, to support the care of patients in their own homes when it's clinically appropriate to do so. I think all of us, working in the NHS, recognise that it is a complex system, and the navigation for patients to get to the right part of the system has in the past been complex. And we've been working very hard as a sector to improve that experience. And we are increasingly developing our capability to be able to direct and to directly refer patients into the clinically appropriate part of the NHS when there's a clinical need to do so. Next slide. Our four overarching clinical themes are around care coordination and supporting the delivery of urgent care. And we recognise that, for example, our 111 call volumes are now well in excess of over twice the number of emergency calls that we currently respond to as a traditional ambulance service. And what we will share with you today is our experience with the 111 First programme at the Queen Alexandra Hospital in Portsmouth, which was one of the first pilots in England, together with a number of pilots in London. But our other key areas of response are clearly around mobile healthcare, and our offer has become increasingly clinically sophisticated now that we've been able to invest and develop our emergency ambulance clinician workforce. Our patient transport service has been growing very significantly in terms of patient numbers over the last few years, and we're becoming increasingly better connected with the leadership across our services in the Thames Valley
through and as our integrated care systems become involved, we are closely involved in those processes, as you would expect. Next slide. In terms of the delivery of integrated care, we have been building sort of our clinical capacity and decision support to enable patients with potentially complex problems to access the care that they need. The traditional sector for us has been clearly the delivery of ambulance care or delivering complex network care, whether that be for major trauma or for vascular or cardiac emergencies, for example. But increasingly, we are looking to directly access same-day urgent care when there's a clinical need to do so. And indeed, increasingly, we can often determine, following an expert clinician telephone assessment, there may be a need to directly involve colleagues in secondary care, and we're building systems and processes to enable that to occur. But clearly what we want to talk to you today about is further developing our relationships and support with colleagues in general practice. Next slide, please. And the area that we're going to sort of focus on today are to try and better manage patients who perceive that they have the need for same-day emergency care. And the 111 First initiative, the first phase of that, has been to develop a new assessment process whereby we want patients to no longer simply just turn up at an emergency department, but to contact the 111 service. Those patients will then potentially will receive a further expert clinical assessment, ordinarily by a general practitioner. And if there is then a need for emergency department care or an alternative, if there's another alternative route to receive appropriate urgent care, then our new systems that Lucy will describe shortly will enable a patient to be directly booked into that service. And we think there are a very large number of benefits in relation to that upstream gatekeeping, which I think Lucy will now describe. Next slide.
Okay, hello, my name's Lucy Stevens and I'm the Director of Operations for our Clinical Coordination Centres here in SCAS. And I've been lucky enough to be part of the SCAS being awarded the first early mover site for 111 First. I wouldn't say it's a journey. It was done so quickly because it had to be. It was probably the equivalent of having a speedboat ride across a very short bay. So very rocky, very exciting, but also took an awful lot of teamwork between SCAS and also our healthcare partners out in the South East Hampshire healthcare economy. So hugely exciting piece of work, it really was, but fast pace, I think, is an understatement. So yes, we were lucky enough to be awarded our model to go forward as an early mover site. And obviously the purpose of this was to test this new 111 First model. And the idea is to educate members of the public not to attend ED without first accessing either NHS 111 online platform or calling NHS 111 before presenting at ED. And we all know the importance of reducing the risk of nosocomial spread with overcrowded waiting rooms in EDs. We don't want that to happen. We do not want to go back to demand levels that were previously experienced in EDs prior to COVID. We know that during COVID, ED departments, EDs often saw a reduction of up to 60% of their self-presenting demand. And so to make ED more efficient for the patient and more effective for the patient, we need to manage things differently going forward. Now we've come out of the first wave of COVID. So we are transferring patients virtually to a group of GPs in a CAS, and then making booked time slots, if clinically appropriate for that patient, to attend ED for their booked time slot to receive the care that they need. And it's also supporting those people who do self-present at QA. At the moment, we're just talking about Queen Alexandra Hospital in Portsmouth, covering the South East Hampshire area. I'll come on to the timeline of what else we're doing later on in the presentation, but the initial early mover was just for QA. So it's how do we educate people and support people who present at QA, and ensure that equity of access to care is still in place and there's no clinical risk to patients who do self-present. So from early May to the end of June 2020, we had to develop and safely implement this model, and went live with it successfully on the 30th of June. Huge amount of work. And again, as I say, the teamwork required for this, I've never experienced before. It's really positive. So we want to make sure that our patients are accessing care in the right place at the right time, both inside hospital and outside hospital, reducing ED demand, to reduce those numbers of people waiting in waiting rooms, and as I've already covered, to mitigate against nosocomial infection risks. Next slide, please. So a little picture there for you. So how to ensure that urgent and emergency care can operate safely for patients. And again, as I've said, reducing the COVID-19 transmission risk, reducing overcrowding in ED, and making sure that we get a higher clinical outcome for patients because they're reporting at the right place at the right time. Next slide, please. So the whole programme, we plan to set up appointments allocated by a GP, located virtually in a clinical assessment service, and this happens. And that's between the hours of 8 o'clock in the morning to 2200 in the evening. Enable this CAS to link to other urgent care treatment centres that John's already touched upon. So it's hot clinics, walk-in centres and same-day emergency care, which that's a piece of work that is ongoing at the moment. And to actively redirect patients who walk into ED back to using 111 first. And that is quite a huge culture shift. And can be quite a scary ground that's never been done before. How are we going to explain to people? What are we going to do with them? They've turned up at ED. What if there's clinical risk there? So if they don't present with red flag symptoms, then they are redirected to a more appropriate setting if required. So these patients are asked to either call 111 or access one of the booths that have been created that I'll go on to in a minute. So they assess themselves using the 111 online platform. And that educating people that ED is reserved for undifferentiated patients in need of emergency care. Next slide, please. So we implemented this in 7 weeks, as I've already said. Which was a huge piece of work, and you can see the table at the chart at the top, which shows all the work streams that were set up, working in collaboration, and all the milestones tracking that went alongside that. And the bottom photograph actually is just to illustrate that estate changes were actually made at QA, and that booths were set up, private booths, confidential booths with iPads, so that patients who were streamed when they first arrived as not requiring emergency interventions were then requested to assess themselves in a booth with support from somebody from QA to come up with the right outcome for their requirements. Next slide, please. So as I said, we created an electronic booking system. We use Adastra in 111. That is the norm for most 111 providers. So we continued as an extension of our Adastra system into the ED by making these booking slots that could be accessed by the CAS. Slots were initially not including children and were not during the out of hours period. However, as the process is becoming more mature, there is work ongoing with the QA team, the clinicians, regarding children, and also can we extend hours of operation throughout the night. As I've said, there's a new covered entrance that's gone into ED with the iPads, and yes, they are bolted down. They are very secure, and yes, they are regularly cleaned, and they are cached. I want to say cached, but I'm told that the right term is cached, so that the next patient can't see the previous patient's assessment. So confidentiality is upheld. As a team, we had to pull together some clear standard operating procedures, and with particular focus for our ED colleagues, the admin teams and those at the front door. They had never done anything like this before. And as a clinical team, pulling together red flags for patients and for the staff dealing with them, how to deal with those instances. So we've got a team of people, sorry, QA have got a team of people. There's an arrivals coordinator at the front door. A senior nurse is overseeing all this area to make sure there's no clinical risk. And QA are also following up patients who do not attend a booked slot to see why they didn't attend, etc., from a clinical risk mitigation perspective. Next slide, please. These two charts just show the percentage of walk-ins that were there prior to us going live on the 30th of June. And walk-in or unheralded patients counted for about 40% of QA's ED attendances. And then you can see when we went live how the 111 appointments then started bubbling very, very nicely. And they remain currently at between 10 and 25 a day. However, they have peaked at as high as 34 on the 22nd of August. And our push is to keep utilising those slots, Next slide, please. Okay, so obviously what was really important to change public behaviour is that we have a robust communication and education package in place. We're all human beings, and if you tell us why we need to do something, then generally we understand and we comply. So we've done a lot of work as a SCAS team and with our external partners during this project. We did a lot of work on with local media coverage. There was some national media coverage, and we also worked with a local radio station called Wave 105. And I do believe, Neil, that you could press that and we could actually hear that soundbite.
Way for you to access urgent care at Queen Alexandra Hospital in Portsmouth. If you need medical help but it's not an emergency, call 111 first. If you're advised to attend the emergency department but it's not a life-threatening emergency, NHS 111 will book you a time slot. Contacting 111 first will help us keep you safe with social distancing and ensure you receive the right care in the right place in a more timely way. If you simply turn up at the emergency department, you may be redirected to the most appropriate NHS service for you. Protect yourself and your loved ones and protect the NHS. Call 111 first.
Okay, so that was our local radio station, and obviously that was very helpful sending that out to members of the public. We looked at the geographical area and targeted some Facebook advertising, website articles, and had some perfect days where my team went down to work with the QAED staff to support them through, and also patients through, doing sort of educating people with the new process. Next slide, please. And this is just an example of the signage that you can see that is evident down at QA. Next slide, please. So obviously we need to focus on learning, very important. There's an academic review being done on the 111 First initiatives by Sheffield University, I do believe. So obviously we're required to make sure that we're reporting and focusing on 5 key areas of learning. Obviously reporting the impact, we need to know, is this working? Otherwise there's no point in doing it. GP clinical assessment service capacity and future commissioning. So as demand increases, ensuring that we've got the capacity there to manage this demand at the right time. We have had some challenges with the 111 online platform, and so we're working closely with the national team on that. That's going really positively, actually. And learning and evaluation using real patient examples to test this model. real patient examples are where you get to the nitty-gritty. Full end-to-end reviews and a number of perfect days and test days. And also greater resilience and technical join-up in SDECs, same-day emergency care services, and that work is ongoing now. That's quite a challenging piece of work, but as I say, that work is ongoing now. Next slide, please. So obviously, we have done some follow-up with our patients as we've moved through this process. Again, it's very new. So as you can see, there were some really positive indicators from patients who did move through the process, which was really positive. Next slide. And that's just some anecdotal comments made by patients who have, as I say, gone through the process, either had a time slot or have been redirected to use the booth and reassess themselves and be redirected elsewhere. Next slide, please. So now we continue. So QA was the first planned early mover. And as you can see, the SCAS map here, where we sit, the SCAS footprint, and the chart on at the top on the right-hand side shows QA there in green, went live on the 30th of the 6th, and all other acute trusts throughout SCAS footprint with go live dates. We are on track with all of them at the moment and working extremely proactively again with our healthcare partners. It continues to be hugely fast paced, but a really exciting piece of work, and I'm really proud that we're part of this. Next slide. Any questions?
So hi everybody, it's great to be part of the new COVID safe PLT. My name is Raj Thakkar. For those who don't know me, I'm the Plan Care Director in Bucks CCG, working across Bucks and Oxford. And welcome to the Cancer pre-recorded webinar. As Raj Baja already explained, questions will be taken electronically and we'll respond as soon as possible. Next slide. We've got a very interesting agenda. I'm going to be talking on inequalities, and then various different speakers and colleagues will be talking on PCN, DES and Thames Valley work, as well as the colorectal pathway, vague symptoms pathway, and how to improve the quality of breast and dermatology referrals, given some of the breast referrals are just for breast pain and could be handled in a different way. And dermatology referrals, given the department is overwhelmed at the moment with work, how we can support our colleagues in improving the quality of the referrals and the quality of the pictures. Next slide, please. So this slide is on inequalities in cancer. It's a really important subject. It comes up in the NHS long-term plan, and like most issues in medicine, there's significant inequalities, and cancer is no exception to that. It also relates to access to healthcare, diagnosis in cancer, care of cancer, and death as well. And for example, in terms of CVD, we know that 40% of deaths in CVD occur in the 3 most deprived deciles, and of course cancer is no exception to some of those rules. So some of the factors that are associated with inequalities include socioeconomic status, and for most types of cancer, survival rates are worse for those most disadvantaged groups. That data comes from Cancer Research UK, but it's multifactorial, and there's lots of evidence that different groups have different perceptions around the risks associated with lifestyle factors such as poor diet and alcohol, and these lifestyle factors are most strongly associated with socioeconomic status. There's also issues around expectation perception in people in the poorest areas of society. In terms of race, there's lower uptake of screening amongst ethnic minority groups, and that's independent of the socioeconomic status of these patients. So, for example, amongst women from minority ethnic groups between 50 and 70, we know that 45% of those patients have never attended screening, which is a really worrying statistic. And there's a clear correlation between the lower than average screening coverage and high numbers of people from ethnic minorities, and therefore we should really be focusing some of our efforts on ensuring some of these groups really do uptake their screening invites. In terms of gender, for the 10 most common cancers amongst men and women, we see that mortality rates are higher in men. For example, every year, 28% of male deaths and 23% of female deaths are from cancer. So there's a 5% discrepancy between men and female genders, and that's from national data. In terms of disability, this is a really important issue. And so in terms of disability, there's evidence that screening, particularly amongst those patients with learning disabilities and those with mental health issues, is significantly different from patients who don't have learning disabilities. So according to MenCap, only 19% of women with learning disability take up cervical screening, and that's compared with 77% of patients who don't have learning disabilities. And similarly, 33% of patients with learning disabilities take up breast cancer screening, and 70% of patients overall. There's also issues around religion or belief, and again, that's perception that cancer is around God's will, and we need to really think about the cultural elements of our patients and their beliefs when we're managing our population health. So there are other factors as well, which I'm not going to go into, but just putting this all together, we as a healthcare system really need to ensure that we focus our efforts on all of our patients, not just the patients who want to engage, but really the patients who are disadvantaged, patients with learning difficulties, and taking into account those cultural differences. So that's the end of my section. I'm now going to move on to the rest of the presentation, where other colleagues will be speaking around the different issues around cancer, in terms of colorectal, in terms of breast, and what sort of schemes we have to help you deliver what we need to deliver as a healthcare system.
Hi everybody, my name's Zoe Caveney and I am the Cancer Programme Manager for Buckinghamshire and Oxfordshire CCGs. Today I'm going to be going through some of the QOF quality improvement module changes as part of the new DES contract, as well as some of the other schemes that we are rolling out within primary care. So this slide looks at the updates from the original guidance that was published in April. These revised requirements were released in September, but are not intended to replace any of the quality improvement activity that has already begun in your practices in response to the original release. Instead, it aims to support practices who need to revise their approach to this domain in year in response to the pandemic by providing a set of national actions which practices should undertake. I'm just going to go through as a quick summary of the main activities. So firstly, there's a focus on restoration of delivery of screening services with a focus on cervical screening. To actively identify women who have had their cervical screening appointment delayed or cancelled due to COVID and ensure that they are offered an appointment. Engage with patients, families and carers to build confidence in primary care and that healthcare can be accessed safely. This could be done through a text or a letter or by engaging with local community groups and the local media. This could be done at practice or at PCN level. To focus on those groups who may experience barriers to accessing services and where there has been a disproportionate drop in activity. To monitor your suspected cancer referral rates and assess if these are returning to the previous levels seen before COVID, and to reflect and identify on where you could improve on. A, the quality of referrals, including how far implementation aligns with guidance, and the awareness of referral and testing pathways. And finally, ensure you have a robust and consistent system in place for safety netting, especially for patients who have been placed on an urgent referral pathway for suspected cancer or have not been referred due to their level of risk or of patient concern around COVID, or have been referred on an urgent pathway but have been downgraded with the consent of primary care colleagues. Next slide, please. So this slide outlines the steps of practices that they need to go through as well as the reporting template that is to be completed, which links back to the actions that we've just discussed. To help support practices in delivering requirements, the CCG have put together a support pack, and this pack includes a help sheet around the DES and the QI module, some cancer training that's available to GPs as well as other practice staff, the timetable of carrying out your actions, some action ideas, a cancer screening PowerPoint around engaging learning disability patients, as well as a GP LD toolkit, which can be used as a communication aid with your LD patients, a patient information leaflet, a link to the CRUK PCM webinar that was launched earlier this year, outlining some of the DES requirements, a summary of the changes of QOF, which we have just gone through, the QOF reporting template, and an offer from CRUK of what they can do to support you. This has been shared with the LCDs, as well as being available on the Clarity TeamNet website if you want to go and take a look further. Next slide, please. So this one is another one that Anant is going to do.
Okay, thank you very much. I'm Anant Sachdev. I'm a GP in Bracknell, Berkshire, and I'm the Thames Valley Cancer Lead, Primary Care Lead. I'm going to mention to you something about Thames Valley Cancer Alliance and the Recovery and Restoration Programme in primary care following this COVID-19 phase. Next slide, please. So the principles for restoration of cancer services, according to the Thames Valley Cancer Alliance, follows a certain sort of group of principles when approaching the restoration. Obviously, what we want to do is make sure that it's collaborative and very integrated, working with the leadership, senior leadership, obviously covering the systems within our footprint and geography, which includes Oxfordshire, Buckinghamshire, Berkshire, and Swindon. The approach is regularly reviewed and supported by NHS England and various colleagues within the Alliance. And really the aim is to develop collaborative local solutions, all supported by all the stakeholders within the Alliance. The key areas that we want to develop include better communication and dissemination of all principles and processes to all stakeholders, to continue to commit ourselves very heavily to working as an alliance, and have a bi-directional, meaning secondary care going down to primary care and primary care coming up to secondary care, challenges to be surmounted within that in a supportive way. The linkages are absolutely crucial between these two sectors, and making sure that we adhere to high quality and safe principles. Clearly, all of this is going to be underpinned by good data to objectively define the focus of care that we need to be providing to the population within our footprint. Next slide, please. So in terms of prevention and early diagnosis, the purpose of various projects within this work stream is the restoration of cancer services in primary care, and that includes encouraging public engagement and raising awareness of signs and symptoms of cancer, because although lots of services have paused, cancer is not paused. We need to improve the 2-week wait urgent suspected referrals. In particular, this has to be focused on to reduce the likelihood of emergency presentations. So there has to be recovery of screening programs in relation to breast, bowel and cervical screening, which have all paused during the acute phase of COVID. And where possible, support the straight to test models to streamline pathways and ensure timely access to diagnostics. Clearly, the new kid on the block, which is the Early Cancer Diagnosis Network contract DES, needs to be supported as well. To home into the specific projects, we have the Quality Improvement Scheme, well known as QUIZ, and the aims and objectives are to restore the 2-week wait cancer detection rates to pre-COVID levels for each CCG, restoration of uptake of the screening programs to pre-COVID levels, to increase breast and bowel screening uptake and cervical screening coverage in targeted groups, individuals with learning disability in particular. And there is a free resource commissioned by the NHS, which a lot of you may be aware of, which is Gateway C, which is there to improve knowledge of signs and symptoms of cancer and increase confidence in when to refer a patient and improve the quality of suspected cancer referrals. I would specifically advocate this learning resource, which I said is free, but there's amazing modules there which have been developed for primary care, and would recommend highly that if you get a chance, please register and use this resource, which will obviously help not only patient management, but also help your appraisal, which is actually a very useful process. Next slide, please. The vague symptoms pathway is another area that we're focusing on, which is to implement this pathway, and there are variations and degrees of implementation throughout the footprint. But we want to aim to actually have access across the whole of the Alliance footprint. Public awareness campaigns I mentioned already, but in specific, apart from various cancers, and certainly the annual monthly cancer calendar is there, but we want to support the restoration and recovery of prostate referrals by holding a prolonged campaign. Remember, November is coming up, which is men's cancers, and this may actually play a part coming up very soon. We want to encourage men to know the risk and tackle health inequalities by targeting the BME populations who are less likely to present to health services and systems. This really we want to build on in terms of tackling health inequalities in a range of cancer allies, and build on national cancer campaigns to target key populations. Data is key, and certainly one of the projects is looking at the Pan Alliance dashboard, which is an interim dashboard solution during COVID to understand demand and capacity and monitor the impact of referrals to ensure they are restored to pre-COVID levels. Primary care is very heavily linked into pathways, and our aim as an alliance is to streamline referral pathways to support recovery. And in particular, we're focused on colorectal pathways and the use of FIT, which you may all be aware of, are going to hear today, and also on prostate and skin, specifically because these have been shown to be able to be reviewed in a very efficient way. Clearly, primary care education is going to support a lot of the primary care workforce and upskilling them in key areas for personalized care, fit-in pathways, lung cancer, and embedding the PCN DES. Now, all of these things are focus for the Alliance, but the care and processes of cancer for the Alliance does not pause, and we're working continually. And we'd really love to hear from all of you in any way we can to see if there's any area we can help and support you. Thank you.
So there are a number of TVCA funded projects taking within both primary and secondary care. To highlight to you a couple of the primary care focused initiatives that are due to take place to try and improve quality of care and experience for patients. The first of these is the Quality Improvement Scheme. A similar scheme was launched a couple of years ago for some selected practices within Buckinghamshire, and this year we are building on from that and offering this out to all practices across the county. The scheme will complement requirements of the DES and the QI modules, and is aimed at increasing uptake in all of the national cancer screening programmes. As you know, identifying cancers earlier means far better outcomes and experience for patients. Due to the COVID pandemic, schemes were paused for a number of months, and so for all scheme rates, rates in uptake have fallen. And so in addition to the activities within the new contract, this scheme aims to provide you with additional support to try to bring uptake back to pre-COVID levels. As part of the recovery and uptake, we want to ensure that there is some focus on tackling inequalities in accessing cancer care. As Dr. Thakkar highlighted earlier, this is an increasing and evident issue affecting all areas of care, including cancer. And so there will be an ask to focus on a chosen, hard-to-reach group. For example, targeted activities to try and improve uptake from those with learning disabilities. We're aiming to launch this scheme in December, and it will run for 12 months, building already undertaken, and there will be payment attached for delivery. An invitation to take part will be shared with you in November, along with the specification which will outline full details of what is involved. Next slide, please. So I also wanted to take the opportunity to just highlight to you the TVCA toolkit. It's a downloadable resource for all GP practice members, both clinical and non-clinical, and provides some really helpful links and information around early diagnosis, screening, etc. The toolkit is hosted on the TVCN website, but you can also access it just by typing it into Google. Next slide, please. And just to give you an idea of what you're looking for, this is what the front page looks like. And as you can see, there are a lot of sections around different areas which provide lots of guidance and examples for you to use when designing your activities to try and improve your screening uptake. Next slide, please. And finally, I just wanted to highlight the Gateway C offer. It's a free online cancer education platform developed for GPs and practice nurses. It aims to improve cancer outcomes by facilitating earlier diagnosis and improving patient experience. All the courses are RCGP accredited and can be used to earn CPD credits. The courses are also supported by Cancer Research UK, Macmillan Cancer Support and other major cancer charities. There are a number of modules that are really easily accessible and won't take any longer than 30 minutes to complete. Some examples of what's available on there is early diagnosis of lung cancer, early diagnosis of pancreatic cancer, responding to a PSA screening request. There's a course around fit testing. There's also some living with and beyond cancer modules, for example, long-term complications of colorectal cancer or end-of-life care for lung cancer patients. So it's a great way to build up some knowledge around this, and a lot of clinicians who have used it have found it useful. So I've just included a link on the slides if you want to go and find out some more. And that's it for me. I'll now pass you on to my colleagues for the rest of the presentation.
Hi there, so my name is Miles Carter. I'm the GP based in Oxford who runs Ardens for EMIS Web, and I'm going to talk you through the Ardens cancer resources we've built, which I hope will make things easy for you to deliver what is required as part of the QoF-QI and Network Days requirements. I'm just going to turn on my screen showing now. Actually, I'm not going to turn on. I'm just going to summarise what we include first, and then I'll go and jump into EMIS Web. So what we've built essentially are some resources to help you with screening, and they are searches to make it easy to identify the patients that need the advice to be given. We've built a template, our cancer safety netting template, which is designed to make it really easy to track referrals for 2-week wait appointments, track urgent diagnostic requests, and also track patients presenting with symptoms that could be cancer, but you're not yet ready to make an urgent referral to investigate that. And I'll come to that shortly. And then we've got alerts, of course, in the standard alerts that you probably see already, which will alert you when you're making coding errors and when you're making diagnoses that could be linked to cancer. I've only got 5 to 7 minutes to do this, so I'm going to go through it quite quickly. There is a pre-recorded webinar that covers this in much more detail on our website, which I'll put the link into at the end of my presentation here. So let me just load up EMIS Web. Now it's EMIS Web, so let's cross our fingers it's going to work. It's been a bit unreliable the last 24 hours, but it's working at the moment. So look, what you're seeing here is the ARDENS searches folder. As you all know, EMIS button, reporting, population reporting drops you into here. Now you should see 9 folders. Now you may not see 9 folders, and that's if you don't see 9 folders, it's because you've not received an update to the latest version of ARDENS yet. You can access these searches from our website, from the ARDENS portal. The ARDENS portal is simply ardens.live/portal, and you can download these searches directly into your system from here if you don't want to wait for your next update. Your next update should be coming quite soon though, but this is how you can access them straight away today if you want to. Back into EMIS. So the search that matters for cancer is folder number 9, the ARDENS Manager National Contract Reports. And in here you've got a bunch of subfolders. I'm going to scroll down to show you what's in there. This webinar is focusing on cancer today, so I'm just going to focus on the cancer reports, but it has got care homes, investment and impact fund, structured medication reviews as well. But let's just focus on cancer for today. So click on the clinical activity folder. What you're seeing here is all the clinical activity in your practice on your cancer referrals, cancer diagnosis, and also cancer screening. That's really an overview of your current status within the practice. It's not really designed for anything more than giving you information at practice level. Now your register is showing your populations. So for example, for bowel screening, here is your bowel screening population. That's all the patients in it. We've broken this down though into BAME, blind, language, and that means language, not English, LD and LGBT, and also safeguarding. And we've done that because it means you can then easily break down your populations, and then you can make some plans on how you're going to invite these patients for their screening. Now, as you can see, we've got bowel there, we've got breast here, and we've got cervical at the bottom there. The folder that matters is the work to do folder. This folder tells you what you need to do to satisfy the requirements of the network DES and the QOF QI. So all you've got to do is run this entire folder, right click, run. That will then run all these reports for you. Any patients we identify here are patients who've eligible for bowel screening, and they've not had that screening done within the relevant time frame, and therefore the advice is overdue. This is your BAME population. Here's your blind patients, non-English speaking, LD and LGBT population. Clearly with the LGBT population, you need to be careful how you send letters to those patients, advising them about screening, and there's a template, the LGBT template within ARDENS, which will give you some further advice on how to communicate correctly with this group of patients. And you've got other and safeguarding as well. So you can choose as a practice how you wish to communicate with these different groups of patients. You might just choose to send one message to all of them. You might choose to break it down depending on their subgroup there. That's entirely up to you as a practice. We're giving you the resource to do that. We're not telling you how to do it, just giving you the resource to do it. Breast screening works in exactly the same way as does cervical screening. So that's the searches. Let's move on to the template. So let's move on to cancer safety netting now. Again, this is part of the network DES, part of QOF QI. It's also good practice, to be honest. The cancer safety netting template, which I'm just launching now, should be available to all of your practices. If you can't see it when you launch it, please just drop an email across to us, support-emis@ardens.org.uk, and we will make sure you're updated to include this in your latest version. This does 3 things, and it makes it really easy. It does referral tracking, it does diagnostics tracking, and it does symptom safety netting. Let's start with referral tracking. At some point in the near future, we will be delivering referral forms directly to your practice through ARDENS. Once that happens, and it should be happening hopefully by December, but it may be in early next year. Once that happens, then whenever you make a referral to the 2-week wait clinic, it will automatically be tracked. And there's nothing you need to do. It just gets tracked and picked up automatically. However, if you're not yet using the ARDENS 2-week wait referral forms, and you're still using DXS or another way to access those forms, then you need to track your referrals manually, because we don't know how reliable the other systems are in tracking them. So let's say you want to make a breast referral to the 2-week wait clinic. Click on referral tracking, click on the drop down for breast cancer there. It's done. That's now being tracked in our system, and it will alert you with alerts in the pink alert box down here when if they've not been seen in clinic 2 weeks after that referral was made. And there's separate searches I'll show you in a second to enable your admin team to track those referrals via a regular 2-week or fortnightly or monthly report. That's referral tracking. Diagnostics tracking, that's where you're going to track referrals for urgent diagnostics. I'm a GP based in Oxfordshire. I know that I've got direct access to certain investigations. I don't know what you've got in Buckinghamshire, but I'm sure you've got some. So, for example, let's say you've got access to MRI brains directly in Buckinghamshire. You can tick the urgent button. That's important. You must tick that button. If you don't tick it, it won't work. Then choose what you're doing an urgent referral for. I'm going to tick MRI brain for the sake of this presentation. I'm going to write here, query neoplasm. That's it. That urgent investigation is now being tracked in the ARDENS tracking system. There's an alert down here that will appear if that result's not appeared in the notes within a fortnight. There's a separate search you can run to pick up these patients as well. Now, the most useful feature, I think, is this one, symptom safety netting. What this does is lets you safety net patients presenting with symptoms that could be cancer, but you're not quite ready to make that urgent referral. I'll give you an example. Let's say a patient who's 50 years old presents to you with dyspepsia, and you put them on a PPI and say, come back in 6 weeks and we'll check it's got better. But if they've not got better, then you're going to want to probably refer them for an endoscopy. At least I probably would. So here's how you would do that. Tick active monitoring of patient. Right here, 6 weeks or 6W. And right here, whatever you want to write. I'm going to write dyspepsia on PPI, query needs referral if no better. There we go. That's now being tracked within the ARDENS safety netting system. There's no further action that you need to take as a clinician. There's messages in the box down here. I'll try and show an example of one. I may not be able to because this is a dummy patient and it's playing up a bit. No, I can't show you an alert for that particular one, but there is an alert that would appear that would say that there's a high-risk symptom that's not yet been followed up in a live EMIS system. And then once you follow them up and you're satisfied there's no further action to take, just tick that box there and it drops them off that register. The reports from that, population reporting, you need to go to the ARDENS main searches, you need to go to the cancer screening search, you need to go to the fast track safety netting searches here. And here are the reports you can run, or your admin team can run, I should say, to allow them to track these referrals and make sure that nothing's being lost to follow up. Like so. That's essentially how it works. Now, there's a webinar which covers this in much more detail on our ARDENS webinars page, which is ardens.live/webinars. Okay, click that button, go to that link, and there's the webinar. That covers everything I've just shown you in much more detail, by much with a view that it's a training video, not a demonstration like this presentation. So please don't view this as your training on this system. This is more demonstration of what you can expect to see in ARDENS. Please use this video as your training on how to use it. Final thing before I finish, of course, is the real-time data quality monitoring. So when any of your clinicians do any work which might indicate a cancer diagnosis that could be missed, we will alert you to it. And I'll give you one example of that now. This patient is 70 years old. If I was to diagnose them with new diabetes, then an alert will appear as a pop-up on the screen and it will say that that could be due to pancreatic cancer. It's uncommon, but it's not unheard of. And it's really important that you ask your clinicians to actually stop and read those messages. I'm going to just let you read this one message I got from a GP in the north of England about 6 months ago, which links exactly to that alert that popped up. I'll read it out to you. It says, "Hi, Miles, some feedback. Within a week of implementing ARDENS, an alert popped up as I was entering a new diabetes code for a 68-year-old gentleman. ARDENS triggered a clinical safety warning and pointed out the nice guidance about pancreatic cancer. The patient confirmed no weight loss, but there was some central abdominal discomfort, which he would not have told us about otherwise. CT scan confirmed malignancy of splenic flexure, pancreas okay." That's a really good example of where an alert that pops up on the screen makes a difference to patient care. So please don't just ignore the alerts when they appear, because they do only appear at least the Ardens alerts only appear for a coding error affecting data quality, possible clinical safety risk, including possible cancer. I think that's all I'm going to cover, unless there's anyone wants to ask me anything from the presenters here. Otherwise, I'll hand over to the next person.
Okay, so hello, I'm Claire Hewitt, Assistant Project Manager for Cancer at Oxfordshire and Buckinghamshire CCGs, and I'm going to talk about cancer care reviews. So the Quality and Outcomes Framework sets out the requirement for patients with cancer to receive a cancer care review by their GP or another appropriately trained clinician, such as a nurse, within 6 months of their cancer diagnosis. The cancer care review provides an opportunity to address the patient's holistic needs and to provide ongoing support and information. It helps the person and their family and all the carers to think through their needs and, together with their healthcare professional, make a plan about how best to meet these needs. It supports them to comprehend their diagnosis, the staging of cancer, treatment plans, potential prognosis and impact. It also helps them understand what information support is available to them in their local area, and it can support self-management as part of their recovery package. The research shows that cancer care reviews undertaken by GPs are variable and inconsistent. Some patients have had extended face-to-face consultations, others have a phone call, and some have no contact from their GP after their diagnosis. The 2019-20 QOF data reports that 93% of patients eligible for a cancer care review in Buckinghamshire CCG area had a review at 6 months, which is fantastic. Next slide, please. So the Buckinghamshire Cancer Care Review Implementation Support Scheme is one part of Thames Valley Cancer Alliance's 5-year delivery plan to improve the outcomes of people with cancer by 2020. It also aligns with the National Cancer Strategy, Achieving World-Class Cancer Outcomes, a strategy for England 2015 to 20. By mirroring how GPs manage other long-term conditions through templates, the Thames Valley Cancer Alliance has produced a template for cancer care reviews at up to 6 months from diagnosis, and for a second review between 6 and 12 months from diagnosis. The second review will pick up on themes that may only be relevant in the later stage of the patient's journey. At present, we don't have data on the proportion of cancer patients that have a second cancer care review between 6 and 12 months, nor do we have information about the quality of reviews undertaken. For clarity, the second cancer care review is not part of QOF. It is an additional work funded by the Thames Valley Cancer Alliance and implemented through the Cancer Care Review Implementation Support Scheme. The template is an exciting way of implementing cancer care review and promoting holistic assessment, support, recovery and self-management. It enables quick capturing of information about the individual that is relevant and important to them, and it means that the clinician seeing the patient will have had that information at hand to maximise the care and support given to the patient. It should also facilitate care planning over time, similar to long-term conditions management. The 2020-21 specification was sent out to GPs across Buckinghamshire in the first week of October, and it's fantastic that practices are signing up to this already. As part of the scheme, practices will need to assign a cancer champion to the practice. We would suggest that the post holder is also the cancer champion for the cancer section of the primary care network, Direct Enhanced Services. Ideally, practices will have a clinical and a non-clinical champion, as it will allow us to pull together a community of practice. However, this isn't essential. As part of the scheme, we're running a primary care event on Microsoft Teams on Thursday, the 19th of November in the afternoon. We have some expert speakers who will provide further information and support on implementing the 2 cancer care reviews and using the template. We're hoping that practices will want to join the scheme, and we're looking for sign up by the 23rd of October, so we hope you'll join us. Thank you.
Right, so I'm Arnold Guder. I'm a consultant colorectal surgeon in Buckinghamshire, and I'm talking today about the 2-week wait colorectal pathway for colorectal cancers and the introduction of the quantitative fit testing into this pathway. And I would like to explain to you how the pathway looks, the primary care component, and the secondary care component, and the options that are within it for safeguarding and safety netting of patients where the diagnosis or where symptoms do not fit the criteria of referral. So this slide you can see is an outline of the 2-week wait colorectal pathway. And the pathway starts, as it has always done, with the NICE criteria for 2-week wait referrals, which will be on the next slide, but I'm not going to move there yet. So an adult patient presents to a GP with symptoms that meet the NICE criteria as they have been. And those criteria were set in 2015 and they remain unchanged at the moment. And the pathway has altered a little bit. So at the moment, if a patient presents with symptoms such as an abdominal mass, a palpable anal or rectal mass on examination, or unexplained rectal bleeding, and they meet the age criteria, which I will show you on the next page, then you can request a set of bloods, including a hemoglobin and a ferritin, and you can refer them on the 2-week wait referral pathway straight to the 2-week wait. Those patients don't need a fit test performed. However, if on examination you don't have any of those findings, but the symptoms still suggest that there is a risk of bowel cancer, and we'll go to those symptoms in a second, then you request the bloods again, including a hemoglobin and a ferritin, and you also request a Q-fit test. So what is this Q-fit test? So the Q-fit test is a quantitative fecal immunochemical test. So it replaces the FOB test, which we all know from the past. It is a much more accurate quantitative test, which is very specific for human hemoglobin. So the false negative rates are much lower. And because it's quantitative, we can set the level at which we would refer patients for further investigation. And there's been several studies which have been running for a couple of years now. This is not a brand new test, but the studies have only come out now demonstrating which level is a safe level to use as a cutoff for referring patients or reassuring patients. And that level has been set at 10 following extensive population-based studies for symptomatic patients using NICE criteria. So with a level of at a level of 10, a level less than 10, the risk of bowel cancer in patients with symptomatic patients, the risk of bowel cancer is in the order of 1 in 1,000 or less. And over 10, there is, with increasing numbers, of course, depends how high the value is, but over 10, these patients should be investigated because the risk for cancer, for high-grade polyps, which are pre-malignant, that are important to diagnose, and inflammatory bowel disease in that whole group is in the order of 20%. So those patients are then referred. So you request the tests. If they are anemic, you don't need to wait for the Q-fit and you can refer the patient on. If the fit test is positive, you can refer them on. And if the fit test is negative, and that's the central box there, a negative fit test, patients can be reassured. However, you need to use your clinical acumen and you need to safety net the patient. So you need to make sure that the patients, a lot of the patient's symptoms would have gone if it was a passing event. If they have persistent symptoms or symptoms of obstruction or other flags that are of concern, you may still wish to refer the patient. And in Buckinghamshire, we have set up the vague symptom pathway. If the symptoms don't quite meet the NICE criteria at this point, you may wish to refer them there, or you may want to discuss it with one of us in our 2-week wait clinic, and there are some GP bookable slots. Next slide, please. So these are the referral criteria for patients. So adult patients, according to NICE, So any patient over 40 with unexplained weight loss and abdominal pain. I think a lot of GPs are not aware of the under 40 guidance. Patients over 50 with unexplained rectal bleeding. So all rectal bleeding patients can be referred. There's no need to do a fit test in those patients. Patients over 60 with unexplained iron deficiency anemia can be referred. An iron deficiency anemia that is unexplained, of course, if you are aware of a cause, then that should be investigated first. And patients with a change in bowel habit over 60. Now, in the NICE guidance, there is still a fecal occult blood, but that's now been replaced by QFIT, which is much more accurate. Palpable masses, of course, and then this group of patients under 50 with the rectal bleeding and one of these other signs, these patients ought to be referred. We know that young patients increasingly are diagnosed with bowel cancer. The incidence is slowly increasing. These criteria have been in existence for 5 years, so please do refer to those and refer them accordingly. Any patients with unexplained symptoms with a positive QFIT, now that falls mostly into our vague symptom group patients. If you refer a patient to the vague symptom pathway and they have a positive QFIT, they are automatically transferred to the lower GI pathway. And it is important for GPs and for us, of course, and for your patients to always do the bloods request on ice urgently, which will allow us to assess them when we see them in a telephone clinic 2 or 3 days later, or at least the bloods are on their way. Unexplained anemia, again, this is self-explanatory. Patients with anemia of more than who are over 60, please do refer those patients. Patients with under 50 with rectal bleeding, those are to be referred, and patients under 60 without rectal bleeding, you can do a QFIT test. Non-iron deficient anemia patients over 60, if you do a QFIT test and it's positive, then they can still be referred. Next slide, please. So this is a slightly different way of showing in which patients you can refer straight away, the red boxes, or patients in whom a fit test is required first. And then there's a group of patients where you need to consider other investigations and safety net them if their symptoms change over time. There's a final comment is, remember that the bowel cancer screening program, which is a screening program for asymptomatic patients, also uses the QFIT now, but they use it at a cutoff of 120 micrograms. So it's not a FIT 10 like we use for symptomatic patients. So if a patient presents with symptoms and they had a negative bowel cancer screening program FIT test, you probably should do another FIT test because they might have a level between 10 and 120, and they should be investigated on the symptomatic pathway. So it's a different value, so therefore regarded as a different test. Thank you. So if you, the FIT testing can be requested in the practice, and the FIT tests have been supplied with an information leaflet, and it is extremely important that the patients read the instructions, that there is a QFIT request on ice, which is printed out and included in this pack when it's returned to the laboratory. Next slide, please. So this just explains that. So in the pack is pre-made up, but you need to request the ice form, print it out, and it should go in the pack. The patient then collects the specimen and return it to the GP as quick as possible, which then returns it to the laboratory at Wickham as per normal, and they then send this on to the laboratory in Oxford where it is processed, and the result is reported on ice. We have a system in place where any positive result on ice will be flagged up to one of the administrators in the trust. They will then chase a result. So if you requested a test and you are not there to look at the result, someone will contact your practice for a positive result to trigger a referral. So a positive test will trigger a referral by contact from the trust. However, we found that most GPs have done that before we contacted them. Next slide, please. This is to do with the advice and guidance slots. So there are some advice and guidance slots where you can actually speak to one of us or one of our doctors in the 2-week wait telephone clinic, usually at 11:15, and it's based on a specific patient. So if there's a patient where the criteria are not quite met, but you are concerned, speak to us and we can then decide which is the most appropriate test. It is often not a colonoscopy. So I think those patients where it's not quite clear, it may require a little bit more thinking and to get the right diagnostic test done first, so we can still adhere to the pathway. If you need any additional QFIT packs, they are available from both Stoke Mandeville and High Wycombe laboratories to keep your stock and your practice up to date. Next slide, please. So this is a contact from Cancer Research UK. CR UK have offered quite a lot of support to run this out through at all the practices in the county. So if you need any further support, they can be contacted on the name here, Louise Foster, on her email or by mobile phone. Next slide, please. So this slide is on the vague symptom pathway. So the vague symptom pathway was introduced in 2019, and this is for patients with vague symptoms who don't meet that criteria for a specific 2-week wait pathway, but the GP has significant concerns that they may have an underlying malignancy. Most of these patients will be patients who have significant weight loss, unexplained or unexplained severe fatigue, but the referral form tells you what the other possible criteria are. A lot of these patients will have colorectal malignancy, and they include a FIT test in their pathway for that, and they automatically refer the patients onto the respective pathways as they diagnose patients from a big variety of different cancer groups. The vague symptom pathway can be accessed through a normal 2-week wait referral form.
Well, thank you very much for asking me to come to speak today. My name is Fiona Sang-Wright, and I'm one of the consultant breast and reconstructive surgeons at the Bucks Breast Unit, which is based at Wycombe Hospital. 1 million women have missed their screening mammogram under the National Health Service breast screening programme, and we estimate that this will be about 8,000 undiagnosed cancers. Clearly, this is of some concern, as we know that the early detection of breast cancer can be associated with earlier treatment and improved patient outcomes. So how has COVID-19 impacted the Bucks Breast Unit? If you have visited our unit, and you're more than welcome anytime, you will see that it is a spacious, modern, purpose-built and state-of-the-art department. And as such, we have been able to easily put in measures for social distancing with large consultation rooms and different waiting areas, enabling us to separate patients during their visit. Next slide, please. This graph shows the number of referrals to our symptomatic 2-week wait clinics this year, covering the peak of the pandemic from March until June, when we probably entered the recovery phase. And what is striking is that the drop in referrals was down to as low as 20%, and this is a record. And this is comparable across other units around the country. We estimate that we have missed probably around 700 referrals during that time. Now, you can look in September, we can see that the referrals have increased and we are back to our busy clinics, but we have certainly not made up the shortfall. And this does not include the screening patients which are coming through now that the screening programme has restarted. Next slide, please. The Trust has therefore made it a priority to restore referrals to pre-pandemic levels across all tumour sites, not just for breast. And the aim is to reduce all the waiting lists, ensuring that there are sufficient diagnostic and treatment capacity in order to meet the increased demand throughout the autumn and coming months. As you might know, October is Breast Cancer Awareness Month, and there is increased media attention on breast cancer. Messages are being sent out across all forms of social media, highlighting the signs and symptoms that patients should look out for when they should seek and when to seek suitable medical advice. All our referrals are coming through the reintroduced Choose and Book system, and we typically see patients within a few days of the referral in a face-to-face clinic. Although we are looking at introducing consultation, you will appreciate that this can be a little bit challenging for our breast patients. We have introduced other innovative changes to ensure that our patients are seen quickly, swiftly, and smoothly with social distancing and COVID protections in place. For example, based on your clinical examination, which is why there is a new checkbox to confirm that the patient has been examined, we streamline the patient's visit by having a direct imaging approach as a first step. And this means that any woman, for example, over 40, will automatically have a mammogram on their arrival in the clinic and may also have an ultrasound scan of the concerned breast if you let us know on the referral letter that this is your worry. We have found that this has significantly improved the patient experience and reduced our patients' time in clinic. We believe that we are making headway in reviewing our missing women. We hope that by highlighting important symptoms, as well as reassuring our patients that we have safety measures in place in the clinic and in the hospital, that we will be able to encourage them to see you and, if needed, be referred on to us. Thank you very much for your time.
Hello, I'm Dr. Sophie Grubczynska, the clinical lead for the dermatology department at Buckinghamshire Healthcare NHS Trust. And I have been asked to give you some tips on how the quality of skin cancer referrals could be improved. Next slide. We are having to do this because we now have fewer slots for face-to-face appointments than we did before, as we have been restricted to only working out of Amersham Hospital for the moment, but also because of social distancing, limiting the overall number of patients that can physically come into the department on a particular day. This was not a major problem at the beginning of lockdown, but since the end of lockdown, the number of 2-week wait referrals is at or close to pre-COVID levels. We must therefore try to make sure that the appointment slots are used carefully and are not wasted. We want to make sure that the patient will be seen by the most appropriate clinician or specialty to avoid multiple hospital visits, which could potentially increase a patient's exposure to COVID, but also delay their treatment. We are not infrequently finding that the standard skin cancer 2-week wait proforma is incomplete and that there is no supplementary letter to give us the missing information we need. Surprisingly, size and site of the lesion are the commonest things not mentioned or are vaguely described, which makes it very difficult to decide whether the patient should be seen in a one-stop clinic where there's a complex surgeon available, or whether they could come to a one-stop clinic when there's a nurse surgeon available that could deal with smaller lesions. Some patients would actually be best seen directly by a plastic surgeon purely because the lesion, the size of the lesion or its anatomical location is best dealt with by them, or possibly because the patient's past medical or drug history again would make the procedure much more complex and best seen by plastic surgeons. New slide, please. So if you could give us as much information as possible on the referral letter, we would be really grateful. It's helpful to know whether the lesion has appeared suddenly, which could suggest it's a possible squamous cell carcinoma, or whether it's been there a long time and festering and just not healing, which could suggest a basal cell carcinoma. We need to know their full past medical history, any relevant family history of skin cancer, any risk factors they may have, such as prior sunbed use or occupation. Obviously, their drug history and known allergies need to be known as well. We also want to know whether they're mobile and can, because if they're wheelchair bound but cannot transfer from their chair to a couch or need a hoist, they will definitely need to be seen by the plastic surgeons, as we do not have a hoist in our dermatology department. We appreciate that attaching a photo can be very troublesome, but they are incredibly helpful and worth a million words. Those of you trained in dermoscopy may even consider sending in a dermoscopy image of the lesion, which can be so informative, especially for pigmented lesions. Many of you are already attaching photographs with the referral, and we're truly grateful. Most of the photos have been sent in by patients and are often not very good quality. If you could change slides. So if you're able to give your patients some tips on how to improve the quality of their photos, that would be a real bonus. Our medical photography lead has put together a list of tips that you may be able to give to your patients. Generally, a distance or orientation shot to show where the lesion is, plus a close-up is a good idea. And if one could place a ruler or an object next to the lesion, it would provide a sense of scale. A neutral colored or plain background, such as a towel, should be used if possible. The camera should be moved rather than use the zoom function to enlarge the lesion. If a macro focus is available, this should be used as well, but it shouldn't be used within 20 centimeters of the lesion. Good natural light, but not direct sunlight, should be used. A flash is helpful as it produces a better image, but if you take the photograph too close to the lesion, it will wash it out. The camera or the phone should be held firmly with both hands to minimize the risk of camera shake, and care should be taken not to cast a shadow over the lesion. Ideally, the photograph should be taken straight on and not at an angle. It would also be helpful to ask patients to maybe choose the 5 best photographs of the lesion and send those in, rather than send you 20 images that are then uploaded. New slide. If sending a photo is really difficult, please specify the size and site as precisely as possible. This can make a huge difference to who ends up seeing the patient. For example, if the lesion is on the lower leg, it would be better to say it's on the shin. Or if it's on the lip, please specify if it's on the vermilion edge. If it's on the lower eyelid, please say so, rather than saying upper cheek. Conchal bowl should be stated if rather on. Size does matter. For example, a 5mm papille on the shin may be amenable to excision and primary closure by the dermatology department, especially one has already factored in the excision margin, which can be anything from 2mm to 5 or 6mm around the lesion. So a lesion that's approaching 1 centimeter on the shin that needs an additional excision margin would most likely require grafting, and this would be carried out by the plastic surgeons. New slide. We are also starting to get 2-week wait referrals for mole checks, actinic keratoses, basal cells. We often read on the referral letter that a possible basal cell or seborrheic keratosis was suspected, but just in case, you will refer it in as a 2-week wait. We beg you to consider getting advice on the lesion first preferably via advice and guidance, marking it urgent so that we can look at it promptly. A brief history and a photo may allow us to advise you whether it needs referral, and if so, whether it needs a 2-week wait, an urgent or a routine. If you do see a basal cell carcinoma or you suspect Bowen's disease, then these can be referred in through the normal method on ERS, but please mark them urgently so that we triage them quickly to the most suitable clinic. For example, a basal cell carcinoma near a critical site like the eyelid or nose may be referred directly into the Mohs consultation clinic. Our aim is that eventually we may even be able to refer patients directly for surgery, bypassing a consultation, but we can only do this if we're comfortable making the diagnosis from the photo and have been given enough information. Thank you for listening. I appreciate there is no opportunity for questions in this setting, so if you have any queries or concerns, please don't hesitate to contact me.
Thanks everybody for listening. What a great PLT, fantastic agenda. We talked about cancer in the context of inequalities, some bits and pieces around the quality improvement modules and PCN DES, really helpful discussion from Ardens around some of the practical aspects of cancer and how we record all of the data in a safe way. Then Arnold talking about the 2-week wait pathway, and of course fit testing as well as the vague symptoms pathway, and then going on to breast and dermatology. So really rich discussion. Please do send your questions in. We'll endeavour to reply as soon as possible. Thanks for your time.
I do hope you enjoyed the clinical sessions that were recorded for you. If you have any questions or queries about them, then please contact the team at members.ccg@nhs.net. You can also click on the link below this PowerPoint slide to receive a certificate of attendance if you need that for your CPD purposes. The next CCG PLT will be on the 9th of February 2021. I hope that we'll be able to meet in person by then. Otherwise, we will hopefully design a similar presentation for you. Once again, I wish you well over the next few months and hope that you keep well and keep safe. Thank you.